All right, good morning, everyone. It is June 29th, 2026 at 8:03 a.m. This is a special Texas Medical Board meeting that has been called to discuss a couple of issues that are on the agenda. This meeting will be open to the public at the above location and will proceed by video conference as allowed under Texas Government Code Section 155.127. The location above shall have two-way audio-video communication with each of the other locations during the meeting. The president or presiding officer of the board will be physically present at the location and room listed above. Please note that accommodation will be available for members of the public to physically attend the meeting at the above location, but will be subject to limitations set out by the Texas Facilities Commission seating. Members of the public are encouraged to attend the meeting by accessing the video conference or audio link below. With that, Mr. Carlton, can we have a roll call?
Yes, Dr. Zaffron,
Present.
Dr. Farmer, Mr. Kokonos,
Present.
Mrs. Barnes, Dr. Bhatia,
Present.
Mr. Crane,
Present.
Dr. Deloche,
Please unmute.
Dr. Deloche, you're muted.
Present.
There we go. All right, thank you.
Thank you.
Del Rosal,
Present.
Dr. DeStefano,
Present.
Dr. Green,
Present.
Mrs. Harrod,
Here.
Dr. Jones,
Here.
Dr. Martinez,
Here.
Mrs. Morgan,
Present.
Dr. Nadeau. So
Please
I'm
unmute. Please
Yeah.
unmute.
I'm present.
Yep, thank you. Dr. Quinones, Dr. Tibbles, Mrs. Troncoso,
Present.
Dr. Vanderwiden. All right, we do have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, I think 14, 12. Count 14. So if any of the others join, we'll be sure to try to annotate it for the record, but you may proceed.
Thank you. The first item on the agenda is, I know, something that is very exciting to all our licensure committee members. It is discussion regarding committee assignments and structure. As many of our board members know, when we have our meetings on Thursdays prior to the full board meeting, we have our licensure committee and we have our disciplinary process review committee. And the way things have been lately, we have had a significant increase in volume of DPRC agenda items. A lot of it also involves appellants who are here appearing in person. When I say appearing in person, it could be virtually or it could be physically here. And we looked at organizing a structure where the assignments would be a little bit more equally apportioned out, and that may necessitate creating a third committee, which would essentially be the licensure committee transitioning into a third DPRC committee tasked with actually hearing appellants and so forth. And then all three committees would come together, essentially would be the entire board, to finally discuss that at the end of the day. We think that may be a way to streamline the process. As it stands right now, the disciplinary process review committee usually goes until about 5 or 6 o'clock. The licensure committee maybe until about 11 a.m. Hopefully we can kind of split the duties a little bit more that way, and all of us may be able to finish a little bit or not as late, and be able to get into a more thorough discussion of all the different cases that are in front of us. Mr. Carlton, do you want to speak a little bit about the structure and what that would look like?
Yes. So the idea, based on our last several board meetings, but particularly from direction to staff at the last one, what we looked at doing is still having executive committee going first, then finance, and then immediately after that, all 19 board members would go into licensure committee. The licensure committee would do like we're doing in DPRC now. It could be split into kind of subcommittees A, B, and C. It would look at things. One subcommittee might take all the eligibility issues. One might take the appearing appellants for licensure issues, and then others may take some other duties. The idea is to try to split it up to where all three are going to roughly end at the same time. They would come back together like DPRC is currently doing. They would vote on any decisions that need to be made for the committee. And then licensure committee would adjourn, and then all 19 would roll into DPRC, do the same thing, split into multiple subcommittees, taking all of the appearing appellants like Dr. Zafran was talking about, other follow-up files, other cases that are set for review and dismissal. And again, roughly try to apportion it out to where they all end about the same time, come back together and vote on any issues that need decisions, and then that would complete the day. As Dr. Zafran said, sometimes DPRC is running until 5 or 6 p.m. in doing this. Hopefully, I mean, hope's not necessarily a plan, but if you look at the way the time has gone, we may be able to get it to where everybody is finishing kind of, around early afternoon. And so instead of having one group end just before lunchtime and another one's finished in the evening, you may all finish, kind of just after lunchtime or something like that. So with your approval, we'll obviously flesh these details out a lot more. And if you want, we can bring this to you to start in August.
Yeah. So is there any questions from our board members on this?
Is that going to be written out so I can follow that, how you explained it?
Yeah. So if we, I think the idea is to change this into a structure that is workable. As you guys know, right now, for example, if you're in DPRC, you receive a list of things that each board member is supposed to be looking at. This would be essentially the same. You'd be listed as to what committee you're in, what are the items in that committee or in that subcommittee that you're looking at, and so forth. And we'll flesh that out a little bit more also.
Yeah, right.
Yeah, the idea is that everybody should have an idea of exactly what tasks they're looking at and which cases they're supposed to be reviewing.
The other
Nice.
benefit of doing this is it should make it better for our appellants and the public that are appearing. Instead of some of them having to wait before their case is heard until 4 p.m. or something, they may be able to have their cases start being heard much earlier in the day.
Gotcha.
Do you need a motion versus information?
Well, I think maybe a motion to look at the structure of the committees in general.
I
Right.
think the item just says discussion, so it doesn't say necessarily an action.
Direction.
So what all you really need is, assuming you guys are okay with this overall idea and you want to try it out in August, you can just say, that sounds great, let's give it a shot.
Yeah.
We don't need an actual vote to do it though.
That sounds
Yeah,
great.
I think this will make it a little bit more streamlined. And like I said, because of the volume of cases that one committee has to look at, I think it'll kind of spread it out a little bit better. And also, as Brent said, I think it is important for each of the committees to understand what the other's doing also, and get a little bit of a better perspective on it. So,
Agree. Ms. Harrod, sorry.
Ms. Harrod?
Yes, diving deeper into what the other committees are doing. I know that prior to me serving on licensure, I was able to shadow a few of the licensure committee meetings. Is there like a difference in process with DPRC than it is with licensure, or is it typically the same type of process in those committee meetings?
Yeah, we're
Yeah.
going to be there. The general counsels are going to be in the meetings with you, the new subcommittee, to guide you and let you know what your options are and what if something needs a motion and all that. So we're going to be there, but I'll defer to Brent on shadowing.
Yeah, I mean, again, that was part of it too, is so that all the board members are seeing kind of what's happening in the licensure, that the ones that are in DPRC see what happens in licensure and vice versa. So yeah, staff is going to be in all these subcommittees. There's really not going to be a lot of decisions that are necessarily going to be made in the subcommittees. Again, you're going to hear the information and then come back and make decisions together as a group before the committee adjourns. But we can also, if we need, we can have staff kind of do some work groups on this if you would prefer.
Okay, I just want to make sure in that August meeting that we're, valuable committee members versus just trying to split up the workload. I want to make sure that I can contribute and know what I'm reviewing and what is expected of me.
Well,
I also think it might be nice to integrate the subcommittees, and meaning take a few of the people who are on DPRC, split them up and put them in that third committee, perhaps with some of the licensure guys. So that way we can be bounce boards or whatever, if you will, often be able to answer some questions if need be.
Yeah, we will try to, again, split it up to where people that are experienced in DPRC are in all of the subcommittees, same thing with licensure. So it's not, DPRC is all thrown into a licensure issue together that they may not be familiar with.
Okay, thank you.
Sounds good.
All right. I don't see any other hands up.
That should complete that one. There may be a more discussion on agenda item number 3.
Or maybe 4.
Well, 4 and also the one. So I guess it depends on how you want to do it. We can do 3 quickly and then and move on to 4, or do you want to do?
Yeah. So let me just kind of have everybody kind of understand what's going on here. So a rule went out regarding ketamine in our previous board meeting in April. And as it stands right now, the proposed rule, as you know, if there are significant changes in what is proposed, it would have to go out again for public comment. So what we're doing here is looking initially in agenda item 3 at the original proposed rule that was put out in April. And there will be a conversation and discussion and recommendation around withdrawing that rule. And then there will be discussion in item number 4 on the new proposed rule that board members have received Saturday morning. So there'll be an opportunity to have a discussion about that, and take some action on that also. Then there's another couple of proposed rules under Chapter 160 and 169 that we'll discuss also, as well as 183. So with that, and that way everybody kind of understands the pathway that we're taking with this. If you look at agenda item number 3, this is discussion, recommendation, and possible action regarding withdrawing published rules under Chapter 173, Office-Based Anesthesia Services, Subchapter B concerning IV ketamine therapy standards, 173.6 through 173.18, approved for publication by the board on April 13th, 2026. Now, once again, this is a recommendation to withdraw these rules. And when we get to the next agenda item, it'll be to discuss what is being proposed by staff for rules for discussion moving forward. So, Brent, is there anything I'm missing on that one?
Just want to say, during the time that the rule that was put out on April 13th to the present, we've received comments, feedback. Some people like some parts of it, some people don't like some parts of it. And so that's part of why there's substantive changes that were going to be made to the rule. And so we wouldn't be able to approve that rule anyways. And so the idea was to just withdraw the entire rule and then try to incorporate some of the feedback we received into the new version of the rule that's in agenda item number 4. So it's not moving away from potential ketamine regulation or these new rules entirely. It's just kind of a cleaner way to withdraw and then continue on with the discussion in item 4.
All right. And we'll get into a little bit more substantive conversation when we get to agenda item 4, but we do need, if you'd like to discuss agenda item number 3 even more, or if there's a motion out there, and then we can move on to the next agenda item. Board members?
So again, here it would be, for agenda item 3, it'd be a motion to withdraw the rule published on April 13th.
Motion
Okay.
to withdraw.
I'll second that, Morgan.
So a motion's been made and it's been seconded. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? All right, so the motion passes. So agenda item number 4, discussion, recommendation, and possible action regarding proposed rule amendments to 22 TAC, Chapter 173, Office-Based Anesthesia Services, Subchapter B concerning parenteral ketamine therapy standards. So one thing that I will say is that, we had a very good discussion group of stakeholders, and an opportunity to hear many different viewpoints. Those were heard, and with that, the new proposed rule that is in front of you was put forth. So I'm going to hand this to Brent because I think what we're going to do is first, I think we may take some public input. And then from that, we'll go into a conversation discussion with the board members, look at the rule as it's proposed currently right now. If there's any amendments that need to be made, if there's any changes, or if it's as is, if there's any questions that need to be answered, and then we need to have a vote on it. If we do pass a proposed rule, same as the process before, it'll go out for public comment, and there would be a minimum of 30 days, which would take it to essentially the next board meeting in August.
Yeah, so again, we've received a lot of comments, a lot of helpful feedback on it. This version of the rule that you guys are looking at today has not been seen by the public yet, but it is based on information and feedback we did receive from the public, and that could be, those that are providing PKT right now, individuals that are physicians, mental health professionals, other stakeholders, veteran groups, kind of a good spectrum across the board of input. So I'll just kind of briefly touch on some of the highlights of some of the changes that we've made. And then at that point, maybe we can take some either comments from the board for discussion, and then we can see also what members of the public might have for us today. So what we did is we did add some more definitions under the first section of the rule. We kind of refined the administration of ketamine. What is an adverse event? We talked about putting in an initial dose, and that's that 0.5 milligrams per kilogram of body weight over a 40-minute period. Definitions of what is a medical director, and we also later will talk more about the requirements and any limitations for anyone acting as a medical director. What is a PKT practice? So the locations that are providing the service. We did refine also the definition of PKT itself. It still is based on IV, IM, and subcutaneous, but we also put in before that there had been some comments about RNs not being able to administer PKT, so that's been added that RNs could do this as far as administration. There was some comments about allowing other mental health providers to be able to have at least the initial diagnosis of a condition that would be a fit for PKT. And so we did add those license types in there as well. Now, again, it would still be a responsibility of whoever is seeing the patient for PKT that they also do an evaluation of that diagnosis, but they don't necessarily have to be the ones making the initial diagnosis. We also define what is a practitioner. And so that would be an APRN or PA for the purposes of this rule. There's still mandatory registration. There's the still existing exemptions from registrations for like medical schools and hospitals. There's or a hospice program. We talk about renewal of the PKT, every 2 years. The medical director, we put a lot more information in here about, obviously it should be obvious, but it wasn't spelled out before, that the medical director has to be someone that has a current, full, and unrestricted Texas medical license. They can't have any disciplinary history or have any pending investigations. You can only have one medical director at a time, so places could not have multiple medical directors operating simultaneously. But you'll have to have at least one medical director. You can't get away with not having one. The medical director's information needs to be, known to the patients, so it needs to be listed in public areas and on the websites and in advertising. As far as the medical director does not necessarily physically have to be at the PKT practice, but they do need to be in Texas whenever PKT is being administered. And again, there's some other requirements here for the medical director. You could have somebody else be the medical director if that medical director needs to leave the state or is going to be on vacation or is doing something else. But again, you can only have one at any one point in time. And also, we did put some restrictions saying a medical director could only be a medical director of up to 3 practices at a time. We have seen some things where, you have someone that's a medical director for dozens of locations, and it's kind of hard to really keep up with oversight when you have that much stuff that you're trying to maintain responsibility for. So for the purpose of this rule and seeing what comments we get, we did limit it to 3. And that the medical director does maintain overall responsibility for the administration of PKT and the medical care that takes place at the practice. So you can't have other physicians that work there that are approved by the medical director, but the medical director also still has concurrent responsibility even for the delegation and supervision that the other physicians are providing. We talk about the operation of the practice. Again, you have to have the medical director assigned in writing. We still had the limitations on, if there's only so many people that can have ketamine administer them simultaneously. So if you have a physician on site, your practitioners can administer it up to 4 at a time. Your RNs can also administer it up to 3 at a time. But if you do not have a physician on site, then the practitioners are limited to 3 at a time, and the RNs are limited to 1 at a time. We also talk about, what equipment needs to be on site, any medications that need to be on site to manage. And then also, if you have a physician is not on site, this is kind of a big one, they need to be able to either, have kind of 2 options. They either need to be able to respond quickly, like very quickly, to be there in person, because that's kind of one of the questions, like, well, what good is it for a physician to arrive 30 minutes after an emergency has begun? So they either need to be able to arrive faster than an EMS could get there, which is pretty quick, or they need to have privileges at a local hospital that the patient may be transferred to for emergency services and be able to help manage that patient. We talk about monitoring, the observation period afterwards. And then kind of the rest of it from there is still kind of mirrors what you saw in the previous rule. And then one thing I didn't mention is whenever they do the renewal of the PKT registration, they're going to have to submit as part of it their adverse event log. So that way the board gets it every 2 years when they're renewing, and they have to keep that information for a rolling 3-year period. Let's see, did I miss anything, highlights as far as any of the changes? Oh, we did say to give people time to come into compliance. Whenever the rule goes into effect, people have to start complying with the rule 180 days after the rule goes into effect. So they wouldn't have to come into compliance the very day that it starts. And that would be for existing clinics. And also we talked about for any new clinics that come online. If somebody has a PKT practice that they plan on opening here in the next 3 months, and the rule goes into effect, say 2 months from now, they wouldn't be expected to necessarily change their entire business model right away. They would still have like up to that 180 days from the time the rule goes into effect. So I think that kind of hits the high points of changes in this based on feedback that we've received.
Yep. A couple of things I would just mention. I know that I've gotten some feedback talking about, that there's, oral ketamine or intranasal ketamine that is being sent into homes, and that may be something that is even more dangerous. I'm not going to disagree with that at all. I think both are important. This rule, from the standpoint of addressing it under subchapter of OBA, office-based anesthesia, is specifically addressing parenteral ketamine. That does not negate the fact that that home-based ketamine, which this does not allow parenteral ketamine to be used at home, is something that may or should be addressed also. Now, the legislature may take that up also, since that involves something that is probably a little bit more wide-based. And does not have a lot of practitioners involved specifically in its oversight, and will probably need a lot of conversation and discussion on what that specifically looks like. From our viewpoint, when we look at delegation, supervision, establishing a physician-patient relationship, those should all specifically apply properly, just like anything else, when you are making a diagnosis and prescribing treatment using telehealth for home-based ketamine treatment. So that exists right now. And we may be looking a little bit harder on that and making sure that we enforce that it's being done in a proper fashion as it stands today. Now, does something need to be done beyond that? Again, I think that's something that the legislature will probably want to take a deeper look at. I know that Several other states have actually started doing that also. So this is a multi-pronged process. The intent of the board here is not to limit the ability of patients to receive possible treatment out there. That is not the role of the board. The role of the board is to make sure that whatever treatments are being put out there are done in a safe manner. And, there is nothing beyond that. So from the standpoint of a treatment that is becoming more and more widespread, and I understand there's a lot of evidence as to its efficacy, especially when you're looking at intractable depression, post-traumatic stress disorder, or even for chronic pain, where it is becoming more and more widely used. It is something that, even though in many instances it's off-label, there's nothing preventing or preempting physicians from delegating or from themselves prescribing this type of treatment. But we also have to be mindful that it's done in a way that is safe for our patients, which is first and foremost the mission of this board. So the attempt by this rule is to, after all the input that we've heard, is to strike that balance of access and safety, and to make sure that that it's consistent from that standpoint, and also to kind of put out a framework of what this would look like even when maybe other medications or types of treatment are being prescribed. I've heard recently of clinics that are doing a combination of ketamine and propofol, for example. What does that look like? What would be the oversight of that also be? And there may be some other medications out there that we haven't even contemplated looking at as to their usage in different types of settings. Part of that is that we are getting much and much better with the type of monitoring equipment that we have, where we can do things in settings that may be outside of a hospital facility. But again, we just got to make sure that the consistency of patient safety and oversight is something that is not lost in that process. It's okay for something to be available in a widespread fashion way beyond the facility, but we still got to make sure that we are doing it in a way that is consistent with public safety. So this rule, which many of you may be seeing for the first time, I think tries to strike that balance. Some of it may look fairly prescriptive, but a lot of it also allows for the use of this treatment in a way that I think when you look at it, it at least gives a guardrail and a pathway of how it can be done, and how it can be done in a safe manner. The one part that I think there may be some discussion about is the physicians being able to respond either in person or able to manage the patient in a hospital setting. There's a very clear paradigm that we've had for many, many years, is that physicians should be able to manage the complications or adverse events that they prescribe, or for the things that they prescribe. Now, here we have listed specifically how we define the adverse events, and I'll just kind of very quickly just mention them, because I think it's important when you look at a lot of the things that we discuss, it kind of centers around what those adverse events are. So adverse event is any event that requires or results in emergency transportation, a compromised airway, resuscitative efforts on the patient. And I just want to make sure that it's clear that resuscitating a patient doesn't necessarily mean that the patient has a compromised airway also. It could be a compromised airway along with other things, or it could be somebody having a seizure, but not necessarily having a compromised airway. So it's a very general comment of a compromised airway, resuscitative efforts on the patient, psychotropic events. As you guys know, with ketamine, there could be dissociative events that happen with it, or other events, especially if they're taking multiple different medications at the same time, along with getting ketamine treatment, hospitalization, or death. I mean, obviously, we're going from one extreme to the other. So a lot of the things that we discuss in here kind of center around how we define those adverse events. When we talk about delegating to practitioners and making sure that those practitioners that you're delegating to have the skill set in order to be able to manage adverse events, this is what we're talking about. So when we talk about a compromised airway, for example, we talk about being able to manage a compromised airway, possibly up to the level of deep sedation, which requires possibly a certain level of training. We're not being very prescriptive of what that looks like, but but it means that you should be able to manage an airway. ACLS by itself does not train you to manage an airway. ACLS is something that trains you to resuscitate a patient that has went into cardiac arrest. So the idea behind managing a compromised airway is to be able to manage that before you get to that point. So ACLS by itself, by definition, then is not enough to have someone manage a compromised airway. Again, psychotropic events. If somebody has a seizure, what do you do with that? Are they trained to recognize what that looks like and how they potentially manage it? And then I think it sounded a little bit intuitive, but we put it in there. You also need to have the medications and the equipment present on at the site to be able to manage those potential adverse events. It doesn't help to say that you're going to be able to manage a seizure without having the medications that you need to be able to manage a seizure. You know, something like that may be easily managed without having to call 911 and sending the patient to the hospital. But in many instances, it may. So that's a judgment call that has to be made by the practitioners or the physicians that are overseeing what's being done. Let's see, what else did I miss? I think that kind of covers all of it, Brent. Was there anything else that we had a lot of conversation about?
Just kind of reiterating what you said, in that, you know, we did get feedback that it looked like the previous rule was placing a lot of requirements on license types the medical board does not regulate, certain trainings, doing things within certain timeframes. And so this, you know, we heard that feedback. And so what this does is it really puts the responsibility on the medical director. And so this, whoever he or she is, that individual is going to be required to make sure that the individuals administering and monitoring within that setting have the appropriate skills and education to manage the patients and any adverse events that may come with that. So that's what Dr. Zaffron's saying. It doesn't really get into details anymore about you have to do this within this period of time and it has to be this type of course. But that medical director is going to be held responsible if there is some sort of bad outcome and a complaint does come to the board.
All right. And just kind of, again, mentioning the idea of if a patient is transported to the hospital, there is an expectation that the medical director or one of the physicians is credentialed and able to manage that patient's issues at the hospital that they're being transferred to, which means that they have to have an affiliation agreement with a hospital in the local area that they are credentialed at and that they can help manage. This is not something where we open up a situation where outcomes may happen and these patients get transferred and we're kind of dumping it onto other physicians to manage these patients. So there is going to be a certain level of responsibility, as we do with any other thing that patients are being managed by physicians in areas outside of facilities, that when and if complications happen, that they have to be able to have a hand in helping manage that so that they're involved in that process. So with that,
Dr. Deloche?
I'm going to go ahead and ask our board members, see if they have any questions before I open this up to the public. So Dr. Deloche?
Oh, yes, sir. Just I went to the medical director side and so the medical director, as far as I read it, he can't even have a remedial plan or anything like that on his record.
So George, remember, disciplinary action is disciplinary. Remedial plans are not considered disciplinary in nature.
Right. Okay.
Remedial plans are non-disciplinary.
Yes,
You're right.
It would not include warning letters or remedial plan or even a letter of concern. It would have to be an actual disciplinary action that would be in their record.
Gotcha. All right. That was it.
All right. So before, again, I open it up to the public, any questions specifically from our board members? We're obviously going to have a discussion with the board after public comment, but before I open it to the public, I want to make sure that we can answer any questions that the board members specifically may have. You've had a couple of days to look at this and go through it. So if you have any questions, let me know.
I have a question, Dr. Jaffron.
What can I do?
The director, whom you say, will they have a CME, continuing medical education, about Cat-mind clinics? That's number one. Number two is the depression and other psychiatric conditions. Who is going to make a diagnosis? Will they be under a psychiatrist evaluation and follow-up? Or else it will become wild west. Everybody will have a clinic, PTSD, anxiety, depression, and there are so many indications and so many doses. We need to have certain CME on these people, just like pain clinics, registration with certain rules and regulations.
Yeah, so remember that
More
the
strict.
CME rules around pain and so forth all came from the legislature. That did not come from us. We obviously need to always implement what the legislature asks us to do. Now, we do require that there needs to be either a diagnosis already made of a psychiatric condition that necessitates treatment ahead of time, or if there's an initial diagnosis being made, it needs to be made by somebody who has the appropriate delegatory authority or by a physician. So that's all clearly kind of spelled out and defined at the beginning of there has to be an initial diagnosis there prior to proceeding on. We do put responsibility on the medical director to make sure that that an appropriate physician-patient relationship is established, that an appropriate history and physical is taken, all these kind of things. Now, again, if a complaint is filed and we go back and look at it and somebody's not doing something within the standard of care, then obviously that's something that we could have a conversation about. But getting to the point of being prescriptive, that's something that we wanted to avoid in this law, because that could be an endless thing. Just like what we talked about when you're delegating, just again, that's a rule that's already there. When you're delegating something to someone else, doesn't have to be even a practitioner, but in general, there's a responsibility in the physician delegating to make sure that who they are delegating to is qualified to perform what is delegated to them. I know I'm sounding a little wordy there, but that's actually very specific. So what we do in this rule is actually be a little bit more prescriptive of what they have to be able to manage when they're delegated these tasks. And part of that is specifically being able to manage the adverse events. And we become very prescriptive about exactly what those adverse events are. So when we talk about a compromised airway, that basically means that when you're delegating to a practitioner, that the practitioner that you're delegating to, it's going to be the responsibility of the medical director for them to make sure that who they're delegating to is able to manage a compromised airway. And that's a way to not get prescriptive as to what that looks like. We're not saying you have to take A course or B course or C course or have something that is hands-on. But what we are saying is that there's going to be a responsibility when you delegate to someone that person that you're delegating to is able to manage these specific adverse events, as well as the medical director and the physicians who are doing it also. They have to be able to manage the things that we listed over here. So again, it's a little bit broader in how we're doing it. Otherwise, it's going to be endless as to trying to list every single possible thing that can happen. But this is just, kind of, in a sense, generically going over the ability to delegate and the ability to oversee the conditions that you are doing. And on top of that, being able to manage it beyond just in the facility, but also in the hospital where that patient may be transferred to if they have any of these adverse events that requires further treatment.
I also checked some of the clinics in Dallas. Only 2 clinics have been monitored by the psychiatrist, and the charges are like $1,800 per each treatment. 4 treatments in 2 to 3 weeks. I know we don't have any thing about how much they charge, but I'm just giving the finances because this is the thing which I got it from in Dallas and Fort Worth area. The amount of money which a patient will pay, the affordability, I think it's beyond the patient. And also follow up, how are we going to repeat the treatment? That depends on the evaluation by the psychiatrist.
So what's in the proposed rule again, is it opened it up more for individuals to have that initial diagnosis they can bring in with them to the PKT practice. That diagnosis they bring with them has to be evaluated for, does the practitioner or physician feel that this is, legitimate and meets all the requirements. But that's kind of what we had in the original rule, is they needed to come in and get an initial diagnosis. So again, based on feedback we received, it's saying that here where it is. All right, the psychiatric indications may have been originally diagnosed by a physician or by an APRN, PA, or a licensed mental health provider, and it gives multiple examples such as a PsyD, LPC, LPCA, and so on, under proper delegation and supervision. So again, those individuals are able to make those diagnoses now in other settings, and so they wanted to be able to bring that in and have that evaluation done when they arrive at the clinic.
My last question is about the compounding drugs of ketamine. Do we have any regulation about the compounding drug? Not the ones with the FDA approved. They can compound any drug they want with ketamine.
Yes, remember that's actually under the oversight of the pharmacy board. Our expectation is that if you are prescribing a drug and it's being ordered and it's being sent to the clinic, that it has to meet the appropriate regulations from that standpoint.
And we have a specific consent.
The consent issue is actually specifically listed on there, yes. If you look at the rule, it does talk about appropriate consent.
Thank you.
Mrs. Del Rosal?
Yes, thank you. I had just a question on the medical director and the clinical privileges. We have, a couple clinical privileges at a local hospital with an emergency department. How do we define, or are we broad in the definition of local? So if someone's, an hour away, is that still local? Because it has to have emergency department, and I'm guessing not every facility might have one. So I'm just curious if we're giving leeway on whatever they define as local.
No, we're not giving leeway. When we say that a patient may be transferred to a facility, that would typically imply that you're emergently transferring a patient to a facility. Typically, if you have a surgery center, for example, most of those surgery centers have an affiliation agreement with a facility that these patients can be transferred to, where they can be managed. So the idea behind that is to make sure that there is a local facility where that patient would be transported, that is able to handle an emergency, that person would have privileges. And we were very specific about not necessarily saying admitting privileges, but they would have to be having the privileges where they would manage the patient in any kind of situation or circumstance like that. A lot of facilities now actually have hospitalists who act as the primary care physician or the admitting physician, with the surgeon or the others who are managing the patient from where they're getting transferred from, working with the admitting physician and helping manage whatever concerns or whatever issues the patient was being transferred for.
So does that mean if one of these facilities, one of these clinics, the PKT, are middle of nowhere and there's not a nearby hospital, they can't operate, basically?
Yeah. So remember that we said that you have to either be able to respond before the EMS can, or have that affiliation agreement. So the idea is if you're, so it's got to be one of the two. So either you're able to respond quickly as a physician locally in that facility, or be able to manage the patient wherever they get transferred to. So there's an either or that's built into this.
Yeah. Thank you. That the or, you're right. The or, it's right there. Thank you.
That's okay. Dr. Green?
Yes, thank you. Brent, Mr. Carlton, when you were talking about when we got feedback, was it feedback on the old rules, or have you worked with stakeholders already on these rules? I wasn't clear.
Nobody's seen these rules up until 2 days ago, when you guys have. So you guys were the only ones who saw this rules as of Saturday morning. Everyone else is seeing this morning.
Yes, we continue to get feedback based on the rule that went out in April, and then that feedback is what made these changes that you see today. And so again, like I said, for simplicity, we just went ahead and withdrew the rule from April instead of trying to make amendments to that one. And so this is technically, it's a brand new rule, even though it's based on a series of rules that have already drafts that have gone through. And yeah, as Dr. Zaffron said, these edits were going until late Friday evening with final edits being made Saturday morning. Scott?
Yeah, just Brent, you might want to touch a little bit on with what Dr. Green is asking, part of the input, you might want to touch a little bit on the focus group that we held.
Yes, like I said, we had a focus group or individual that had already provided comments previously and had spoke at the April meeting. They were invited to come and talk about that rule, the April 13th version of the rule. And it was kind of a roundtable discussion. And so it wasn't a conversation that was really directed and led by the board. We were more facilitators for the conversation of the members of that focus group. And based on all that input, I think that lasted about 4 hours. Based on all of that input, that's kind of how we got to this version you're seeing today.
And are you allowed to tell us who was in the focus group? I don't know if it's important.
Yeah, I don't have the list in front of me. We had members from, I think, Transcend was the one that we used a lot of their comments on as a baseline. We could have taken the rule from April 13th and then tried to make changes from there, but they kind of gave the most substantive amount of changes and red line that you kind of track and see the differences in. And so we use that as the baseline for the discussion, their version of it. But we had physicians, we had PKT practices, we had the nursing groups, ASPK3. We had nursing group representation, kind of talking to us about, hey, be careful. It looks like you guys may be going into the path of regulating nurses again, which is not what we're trying to do, but trying to kind of set up more of what the physicians are required to do. So that kind of made these changes also. So yeah, it was a pretty broad group of individuals that gave their feedback.
Thank you.
Yep.
Dr. DeRosal, want to say anything else, or? Mr. DeRosal, sorry.
No, I think we've got one hand up for DM. I'm sorry, I can't see who that is up there. But if the board members don't have any other questions, then we can start taking any comments that the public may have. Again,
I just appreciate the promotion.
To Dr. Del Rosal.
I'm ready. Thank you.
Anytime, you got it.
Yeah. Again, this is going to go out, assuming the board approves this, which, maybe you don't, maybe you make changes to it. But if you do, as is, it'll go back out for another 30-day comment period. And I can assume that we're going to get more feedback on it. We may have another focus group to talk about this some more. We'll kind of see the level of kind of the initial responses we get. And then the idea, as Dr. Zaffron said, is this is going to come up at the August board meeting for further discussion of either adopting this rule, making non-substantive changes, or if it needs more substantive changes, which would require another 30-day comment period, or whatever decision the board makes from that point going forward.
So let's take DM, and I see Dr. Clark on there, and then we can move to those who are in the room, and then we can go back and see who else has raised their hand on here.
Sure. Okay. Your hand raised? Yeah, if you go ahead, just state your name. Again, sorry, I can't see it very well on here.
But DM.
Yeah, but go ahead. Dan, is it Dan? Okay. We're not able to hear you. If you are
If you're muted, you need to press *6 to unmute yourself. If you're on the phone.
Yeah, and these comments, when we get started here, and it'd help if we can get a timer up. We are going to limit to 3 minutes for the comments. All right, DM, we will come back to you. You can leave your hand up. We'll go to, says Dr. Clark.
Yes.
All right.
Thank you.
You need to unmute. Yeah, go ahead.
Dr. Zaffron, members of the board, thank you for the opportunity to be with you again. My name's Randall Clark, and I am the current board chair of the Anesthesia Quality Institute and a past president of the American Society of Anesthesiologists. Today, I'm speaking on behalf of ASA. I appreciate the board's hard work on this issue and its attention to an area where clinical practice has expanded faster than the regulatory structure around it. ASA's concern is straightforward. When parenteral ketamine is administered, the safety standard should reflect the pharmacology of the drug, not simply the intended psychiatric indication or the intended level of sedation. Ketamine is classified as a general anesthetic and hypnotic agent. It can produce sedation, dissociation, impaired responsiveness, airway compromise, hemodynamic instability, and prolonged recovery. ASA does not recognize subdissociative as a separate safety category that removes these risks. Sedation exists on a continuum. And as an aside, the sedation continuum statement that ASA has produced was written in 1999 by a name that you might recognize under his leadership, Dr. John Zerwas. A patient intended to receive moderate sedation may become deeply sedated, and a patient intended to receive deep sedation may enter general anesthesia. That is why national and international sedation standards emphasize the same core principle. The team must be able to rescue the patient from a deeper level of sedation than intended. Rescue is not just observing a monitor. It includes airway management, cardiovascular assessment, medication decisions, escalation decisions, and judgment about whether continued therapy remains appropriate. For IV hypnotic and anesthetic agents, ASA believes physician involvement and physician presence is essential because complications occur in clinical time, not administrative time, in seconds, not days. A physician who is not physically present cannot manage an obstructed airway, examine a deteriorating patient, or direct bedside rescue in real time. ASA supports responsible access to ketamine therapy, but responsible access requires physician accountability, appropriate monitoring, emergency readiness, and meaningful on-site physician presence. I urge the board not to create an exception in these rules that falls below established sedation and anesthesia safety principles. Thank you.
Thank you.
Thank you, Dr. Clark. And as I had mentioned earlier, after those initial two, unless DM is available to talk right now.
DM, are you able to, is your microphone working yet? What you may need to do, we're still not able to hear you. What you may want to do is log out and just come right back into the meeting, and we'll get you, still in line to speak.
Okay, and with that, I think we can.
Next is Carl B.
Or do you want to go to those who are present now?
Oh, sure. We can do that. You guys have any comments you want to make? Yeah, come on and make sure the light is on, the way everyone can hear you.
The way we're going to do it, as part of your 3 minutes, you can ask questions, or we may or may not be able to answer. This public comment is kind of, but go ahead and speak your 3 minutes, and then if I can answer, if our lawyers can answer any questions, we'll do so.
Gotcha.
All right.
I'm Kelly Light, RN and co-founder with Transcend, and I do appreciate the thoughtfulness that y'all have put into this, and feel like it's come a long way. As far as the physician having the privileges at the local hospital, so our medical director works in the emergency room at Fort Hood, and we're in Central Austin. So if there was an emergency, we would probably go to Seton, Maine. So would you require then that when EMS came, we went to his facility? I mean, that's still local. So would that work within your requirements, or?
So when we talk about a patient needing to be transported, usually it's going to be in an emergent type setting.
Mm-hmm.
So, and again, you guys can weigh in here, but the idea is one of two things. Either the physician is able to respond in a timely fashion before EMS is getting, I would say it takes, I don't know, usually it's going to take about 5 minutes for EMS to get there. But let's say it's even longer than that, then there must be a physician who's able to actually respond in a timely fashion to be able to manage any kind of complication or issue. Or if it's going to be transported to a hospital, remember that it doesn't necessarily have to be the medical director. It could be one of the physicians that the medical director assigns as being one of those who's able to manage things. So we talked about medical director being the one who's overall responsible, but there could be other physicians that are overseeing under the medical director's direction, who's overseeing things that are available to go to whatever that local facility is to be able to help manage that patient. So again, let's say that your closest local facility that you have an affiliation with is 10 minutes away. And the physician that is helping oversee things that may not necessarily be the medical director is in that area, but can't get to your facility within that 5 minutes that the EMS person can. That patient would be transported to a hospital, potentially would get managed somehow. The idea behind this is to make sure that the physician who's overseeing things at the clinic is able to go and help co-manage things at the facility that the patient's being transported to. Again, just like any other type of thing where you have a complication in a surgery center, in a facility, in an office, whatever that might be, there's always these affiliation agreements where the patient's getting transported to for emergency treatment, that physician is able to help co-manage that patient.
So really, they have to have privileges or have a physician that they've delegated to that has privileges at the closest hospital to the PKT clinic.
Not necessarily the closest, but one of the close hospitals in the facility. I mean, you may have a hospital that is across the street, or you may have a hospital that is an exit away. And you may have an affiliation agreement with the one that is an exit away. So it's not being prescriptive about which hospital that is. You know, I practiced in the Woodlands, Texas for many, many years. There are 3 hospitals, literally one exit after each other. It's not being prescriptive about which hospital that you have to have privileges in, but it's got to be something that the emergency vehicle is going to transport to the facility that you have an affiliation agreement with. Now, it can't be something that is an hour away. When you have hospitals that are right around that area, it's got to be something that is fairly quick that they can get to.
Okay. All right. Thank you for the clarification.
Sure. And if it's vague in the rules, it's vague to allow for that kind of flexibility, because the more prescriptive you are, the more difficult it is to actually meet the criteria. So we're trying to give a little bit of leeway and flexibility as to how we define it. But I think hopefully by the way I explained it, you kind of understand what we're trying to get to.
Yeah, and again, as Dr. Saffron's saying, it's trying to get away, because I mean, the problem is where we come from is we see people trying to kind of shirk responsibility a lot. The vast majority of physicians do exactly what they're supposed to do. It's the ones that get to us that are like maybe not doing what they're supposed to do. And so that's why we have these things in here about, well, there has to be a medical director. There can only be one, because we've had them where they have multiple medical directors, where the medical director is saying, well, yeah, I come up with all the protocols, but I don't do any delegating and supervising. You got to get some other physician for that. And then whenever a complaint comes in, that other physician is saying, well, the person I was delegating to was just doing what the medical director said they had to do. And it's this finger pointing and so we want to make sure, as he said, it's not somebody does something they're not supposed to do, and then the problem just gets dumped off on some other physician or facility of like, well, you fix the problem that we may have created. You know, you have to have some responsibility in responding to that. That's what we're trying to get to anyways with this. Anybody else have any questions or comments?
Hello. So I'm Will. I'm a nurse and paramedic at Transcend. I guess the main clarification that I'm curious about is just around the telehealth prescribing. So are the telehealth prescribers, these companies, sort of required to register with the board, do any adverse event reporting, check a PMP database, check a pregnancy test, like any of these other regs that are on the clinics? Is that in this new set?
So as I mentioned earlier on, this is only affecting or impacting parenteral ketamine. And as we're defining parenteral ketamine, that is IV, IM, and subcutaneous. If a telehealth company is making the initial diagnosis that is going to be utilized when a patient is going to be treated at a clinic, then yes, all these rules do apply to them. As I said at the very beginning, this does not apply to ketamine that is being prescribed for home usage. And as it stands, this basically says that in Texas, you cannot prescribe IV or IM or sub-Q ketamine for home usage. As I mentioned earlier, I do agree that there needs to be a lot more oversight. And I know that you guys made that argument in a letter that was sent in. 1,000% agree that there needs to be some oversight over that type of prescribing and oversight. What we're saying is that this is specific to this. And there will be conversations about oversight over everything else, intranasal, PO, whatever that might be. That is appropriate. Now, we are kind of getting closer and closer to the end of the year. And I know that this is a wider issue that legislators, elected officials may want to weigh in on. And so as this is a wider, larger issue, we are addressing something that we see as an immediate need, because this is kind of under office-based anesthesia rules where there is something already in place, but we needed to adapt it specifically to ketamine. What you're talking about is a little bit wider and probably needs, like I said, some input and some guidance. And legislators in the past have said, medical board, we want you to go ahead and come up with rules and regulations around it. But because it has a wider impact and a lot more stakeholders involved, I think it is appropriate for legislators to weigh in, as they have done in many other states. Georgia just recently passed a law regarding this. So this will be addressed. And again, I recognize the concern that this is only addressing one part and not another. But rest assured that we are not forgetting that part. This is just specifically addressing the parenteral use at the moment.
Well, thank you for that clarification. I mean, I would argue that the timeliness to address that is probably greater than in the clinics, which, I think to understand, sometimes, I've even seen ads for ketamine, on social media where you can click through to actually paying for the ketamine prescription within 30 seconds. And it has like a little disclaimer on there about, there will be some sort of telehealth visit involved with this, whatever. When you've already paid for the prescription, these sort of corporate practice of medicine challenges, there's going to clearly be a bias towards continuing that prescription without a PMP database check, which becomes incredibly relevant in the clinic all the time.
Yeah.
And so I would just encourage a lot of timeliness to address that problem.
So just as I had mentioned earlier, the establishment of physician-patient relationship has not changed. And I have seen and may have tested myself what you have just described, and you're absolutely right. But I would argue that as things stand today, that is not appropriate. Yeah. And, again, we are a complaint-driven agency. I would hope that anyone out there, and I will very, very clearly use the word anyone, because you don't have to be a patient or someone directly involved. But if you know, or you've seen, or you have firsthand knowledge that the proper way of establishing a physician-patient relationship, actually speaking with someone who is a professional that is licensed to prescribe, or actually to diagnose initially a condition, and then is licensed to prescribe appropriately, those rules are in place. Telehealth rules, there are very specific rules around telehealth and how a physician-patient relationship should be established and how things should be prescribed and diagnosed and so forth. I am very aware of what you're saying, that is not happening. What I would say is, even before we even get to addressing that specifically legislatively, the rules that we have in place very specifically address what you just described. And when or if we get complaints that discuss something that have concerns about an inappropriate physician-patient relationship being established prior to somebody being prescribed something inappropriately, we can act on that today. So does it need to be more spelled out specifically for that? That would probably be helpful. But what I would argue is, from a timeliness standpoint, we can act on these things today if we hear about it and get specifics on it. And my lawyers, Brent, Scott, Chris, you guys can weigh in on what our process is as it stands right now, but we should be able to address exactly what you described today.
Well, good. I just curious if it would be, is there a reason why we could not at least, adverse event reporting, PMP database check, these like super basics? Because if we can limit parental administration at home, it seems like these just a couple of other details would have massive impact very quickly and provide a lot of clarity for when y'all are actually trying to regulate this.
Yeah, there are certain things that I can do short of actually passing a rule. There's an address that the board president puts out on a quarterly basis. I think it may be appropriate for me to remind everyone exactly what the rules are. I can't remember if PMP checks are automatically required yet for ketamine. I know, of course, for scheduled drugs they are, and that would require a legislative change, because as it stands right now, the PMP check requirements are for very specific drugs, opioids, benzodiazepines, Crispridol. So in order for it to be expanded to involve these, and again, I'm not saying that I agree with you, they should, but I can't mandate that right now because the law doesn't say yet that I can. And we have to be very careful when it comes to rulemaking that we are not making law through rule. Rules typically will go ahead and clarify or expand on law that already exists. So we can put out there what the board rules and the statutes already require, but expanding that as far as, again, appropriately so, because things are being used for things that we never really imagined or envisioned when a lot of these laws were passed, that these may need to, they will need to be expanded by statute. Scott, do you want to weigh in more? Scott, Mr. Frischauer is our general counsel, so that's why I keep on referring to him.
Yeah.
Well, yes, Dr. Zafran, I could, but you've really thoroughly kind of touched on the issues that we're dealing with and the immediacy of the ketamine clinics as they were. But again, as you've described, the telehealth and telemedicine rules under Chapter 111 of the Occupations Code already fully address that. They say in there that the physician or the telehealth provider, and again, just to clarify and not to confuse the issue, there's telemedicine and there's telehealth. Those actually are two different defined types of practices, but they cover the same universe that we're covering in this rule. But again, what they say is you have to do this, you have to meet the standard of the care, the same as if it were an inpatient office visit. It clearly defines what a valid prescription is. It clearly defines how you establish a doctor-patient relationship and goes through all of those things. So again, you can do a rule, but this statute, as to what the speaker is addressing, the telemedicine, telehealth rule in Chapter 111, the Occupations Code, already fully addresses that. And as you said, Dr. Zafran and Mr. Carlton can confirm, Mr. Palazzola, the Director of Operations, we get complaints and investigate these all the time on those things. So if we get a complaint, about prescribing, for example, and it's over telemedicine, telehealth, we get medical records, we look at the PMP, we look at the prescription. So again, it's already fully addressed. The ketamine with the subcutaneous, the IM and the IV really were not and are not addressed by the telemedicine rule at all. But again, what you're asking for is already in place. Now, does it need refinement? Probably so. But again, because of the nature of Chapter 111 and what the legislature has already been done in that respect, that really is a legislative area to address further, but the framework is already existing.
Yeah, I definitely think that very specific clarity, because none of these telehealth companies are going to register. None of these companies are going to report any adverse events to you, like under the current rule set. So what I saw was, as soon as we even started discussing these rules, when we discussed registry to the board, there were multiple clinics that closed down. And so I think that one thing, like, pretty much set apart the bad actors from the good actors very quickly, even the discussion of registering. And so I think even just moving on, hey, please register with us, and adverse event reporting will close down any telehealth company that is like, hey, just pay for the ketamine before we, do that. So I strongly urge that one.
No, I think you're touching on something that, like I said, has given me heartburn quite a bit, because I've seen how loose this is out there right now. Whether you're prescribing ketamine or whether you're prescribing Adderall, or even whether you're prescribing antibiotics, there's got to be a physician-patient relationship established. There's got to be a proper evaluation done. Now, ketamine, as you're aware, because you're sitting here discussing it, can potentially have some significant effects. And that's why there's a lot of concern. We've seen a lot of reports in the news media of folks taking medications at home and having dissociative events. The struggle that we're having as a regulatory agency is that, from a legal standpoint, we have guardrails as to what we can do. And as Mr. Frischauer said, there are things in place today, if we hear about it, that we can do. Now, it's going to be very difficult for us to just de novo go and require clinics or telehealth companies to register for prescribing a certain medication, because what's to say it's this medication when it may be another medication that also may have certain effects. So it kind of opens up a little bit of a Pandora box. And that's why, you know, it's like one thing may lead to another. It may make sense right now for this specific circumstance, but everything has a secondary and a tertiary effect. So the rules that we have in place, again, we have to hear about it. We have to know about it. And it doesn't need to be a patient that lets us know. If somebody knows and can give us details about it, we can appropriately investigate. Mr. Palazzola, who's our head of operations, that's his job, you know, to investigate these kind of things when we do get these complaints as it exists today. Do we need to expand ketamine specifically as a drug that needs to legislatively require a PMP check? I think that is something that we can debate, or at least the legislature can debate. Does there need to be some specific oversight? And again, it's not about ketamine. It's also about ketamine, but the next drug that's out there that may be utilized, or the next drug that's out there that may be utilized. It's hard to pass legislation or to have rules on a specific drug, and that's why we try to broaden it to the type of drug as opposed to the specific drug. I know that was esketamine? There's a couple of other variations of ketamine that do have specific rules and regulations around them, but it's treated or discussed or looked at separately from other forms of ketamine. So it really gets into the nuances where it's going to be like playing whack-a-mole. And I think that's why we said that the legislature needs to probably weigh in on it. It's a wider issue. It may need to cover things more than just ketamine. I mean, there has been talk in the federal government about possibly making ecstasy a schedule, I think they said Schedule 3 drug. You know, what does that look like if you prescribe that? I mean, these are drugs that we look at as being drugs of abuse. And all of a sudden, they're potentially going to be out there as Schedule 2 or Schedule 3 drugs. THC is already being looked at in a fast-paced manner to become a Schedule 2 drug. You know, what does that look like if you have THC and ketamine along with other drugs? So again, this probably needs a wider conversation with a lot more experts and a lot more conversation, because things are moving faster than our ability to regulate it. So what we're able to do today is to address one component of it. We can reinforce the rules that are in place to address what's going on outside of these clinics using telehealth, and then a wider conversation with the legislature about the wider impact of what we have today, but also what may be coming down the line. The legislature 5 or 6 years ago wasn't going to address ketamine because its form of treatment, as it's being discussed today, was rarely in existence. And again, I've already seen clinics in Dallas that are giving ketamine and propofol together, which again gives me a lot of heartburn. So again, we will reinforce the rules as they exist and make sure that everyone is aware and knows what the rules are and how it needs to be applied outside of what we're talking about here, like in telehealth prescribing these medications. And like I said, if you know about these and have specifics, let us know, and we can investigate them.
Sure, I'll just use my last 30 seconds here. So with MDMA specifically, should it clear the FDA and become Schedule 3? If there was a company that was doing daily prescriptions for MDMA or giving doses way out of the normal threshold that weren't unsafe, wouldn't y'all shut that down like real quick?
So just like opioids or anything else, or any type of treatment, we look at what the standard of care is. So when we get a complaint that something is being done, and if we look at it and we see that prescribing, like, again, I'm just going to use the example of opioids. You know, the CDC for a while had talked about 90 morphine milliequivalents being the standard at which you need to refer a patient from a primary care doc to a specialist if you're going to go beyond 90 MMEs. That was confusing to some folks, because then the regulators in many places actually started going after anybody that was being prescribed over 90 MMEs. And that's why just going after a specific dose, we got to be very careful with that. But to your point, if somebody's doing an evaluation and prescribing something haphazardly that is outside the standard of care, and I'm using my words deliberately here because I don't want to say just using large amount of drug is outside the standard of care, but if it is, whether it's MDMA or anything else, then that is something that we would act on. Now, who defines what the standard of care is? It's the physicians in that specialty that are licensed in the state of Texas. It's not us. So when we get a complaint about something that is a standard of care, we will ask one of our expert panelists, who are, again, licensed physicians in the state of Texas, what is your opinion of what the standard of care is? And if they come back with us and they say, using this amount of MDMA is clearly outside the standard of care, then we can act on it. So it's not us who's defining it. It's actually the medical community out there that is defining it for us.
All right. And then just so your awareness, there is a case report of a patient being prescribed 1,200 milligrams oral ketamine at home. There is daily ketamine prescriptions being administered right now in Texas. We have patients leave in droves to this. And so, again,
let us know.
Well, I did send you an email with the major priority companies.
No, I understand. I saw the email, but to open up an investigation, we have to have specific cases.
Yeah.
Because those are what you're talking about when you send an email, we're talking about a general policy now.
Yeah.
And I kind of described to you from a policy standpoint what we're able to do and what we're not able to do. But when we talk about specific cases that are happening, that is something that when we receive information on, and Chris, you can maybe describe that a little bit, we open up a specific investigation. We look at that specific case. We can subpoena records. We can subpoena what kind of arrangements the company has. It's more of a very specific investigation. And if that leads to a sanctioning because of what they're doing or how they're operating, that's the pathway to doing that. It has to kind of go through that pathway. We can't take something that's theoretical. We can take something that's theoretical and talk about policy in general, but as far as acting against someone specifically, that has to be an investigation that we open up, that we look at information, we look at records, we look at possible harm, and then we act on it. And Chris, do you want to?
Yeah, we really need those basics, who, what, when, where, time, date, place. I mean, it's the complaint that just says this company's doing business in Texas and they have reckless practices. We don't have the type of authority that an assistant U.S. attorney would have, where they could send a broad subpoena. I mean, can't go on a fishing expedition. So we need to have an idea of, these 10 patients or this patient, date of birth, whatever, if we can. Even if there's not a patient, if we have a practitioner and, they're prescribing something, and there's a pattern, there's some things we can do, but generally it should be a complaint that identifies, that who, what, when, where. And that gives us a lead to go in. But if you've got a practice that is routinely prescribing doses that are outside of the standard of care, and you have at least a provider name for us, we can pull up PMP reports and look at that history for that provider, and then potentially do an investigation that way too. But we just need enough information that it's not just, hey, I think this company's bad, you should really go investigate them. That's not enough.
And that's a legal standard. That's not just us saying that. We don't have the legal authority to just open an investigation just because. But we're kind of hinting at you what the pathway is. You've just got to give us enough to be able to open an investigation, and then we can go in and see if there's something that we need to, we can expand our investigation based on what we find. We can refer it to the appropriate authorities if it's something that we think needs to be addressed beyond our own authority. But we've got to have that initial, information to at least open up an investigation.
Well, promise me you'll do something about it.
I can promise you that if we get a complaint that necessitates opening up an investigation, we will do that.
Sure.
Okay.
Hi, I'm Annabelle Morris at Transcend, a therapist. Listening to the last conversation, I think there just is an inconsistency, because as a therapist, what you were just talking about was the prescribing regulations around telehealth, but what then we're regulating is the administration regulations in the clinic. So I'm just curious, there is no guardrails of safety around administration from the telehealth, after the telehealth person prescribes it. So just as it stands, somebody could get that prescription. Theoretically, then they could come to my, a therapist's office, right? Have that prescription, do a ketamine therapy session with a therapist with no medical person on site. But then if I'm working in a clinic and there's IV and I'm doing a ketamine session, there's all these, we have to have this relationship at a hospital, all this stuff. So I think that's part of the frustration, is just how much of a loophole is open. of like that is that like just with oral ketamine having a bigger airway risk, like it doesn't necessarily make sense that there's going to be so much regulation put on the administration in a safer setting. And like there's nothing on administration with telehealth. Like there's not even a regulation that the provider has to be on screen with you during that, like you even know where the nearest hospital is, that maybe like are the patients even fully informed that like there is an airway risk that could happen. And so I just wanted to kind of consider like the pathway that people could take loopholes, or like could someone get it from a telehealth person and then go into a clinic setting but kind of bypass this. I don't know, like I think we are trying to do like add safety, right? But like I think talking about just the prescribing versus the administration is kind of the difference, I think.
No, I hear you. But again, the administration of a PO drug, and I hear you. I mean, trust me, because again, I've seen cases where even taking things PO can lead to dissociative conditions. But, you know,
and it's riskier too if the patient's self-administering.
No, I understand. But let me give you this scenario. You're prescribed 30 days worth of, as a chronic pain patient, you're prescribed 30 days worth of OxyContin. And you decide to take all 30 of them at the same time. We don't specifically regulate, taking your pain medications in a certain setting being overseen. Now, in an IV setting, things obviously happen, in a way that is immediate and so forth and so on. But even by the standard of medications that can be taken orally outside of this, if you take it inappropriately or not as directed, bad things can happen. Now, if you're being instructed to take it in a way that is unsafe, we can regulate that because that's outside the standard of care. But again, that's a wider discussion why we're kind of shifting it to the legislature, because there's a lot of what ifs. And then, like I said, I can give you 100 different scenarios of other drugs where the exact same thing can happen and be done. You take enough OxyContin, you'll stop breathing. I mean, no ifs, ands, or buts about it. You take OxyContin along with Xanax and Ativan, you're going to stop breathing. But these are not ketamine. So it's a discussion that involves something way beyond just even PO ketamine. It involves appropriate prescribing, diagnosing, et cetera, on whatever drug it might be and the possible sentinel effects that it may have. If a chronic pain doctor prescribes pain medications and doesn't clearly instruct that you cannot take this in a certain way and go driving, and then they have a car accident because they didn't get those instructions, that is something that we may have to act on also. So it's not just the ketamine. I'm kind of giving you those examples, just kind of explaining how it's a wide range of things that you could have that exact same conversation about. It's hard to regulate every single scenario out there, but what we can regulate is appropriate diagnosis, appropriate prescribing, appropriate instructions. And part of appropriate prescribing is understanding the mindset of the patient that you're prescribing to. If I think that patient is unsafe and unable to understand and listen to instructions, then maybe that is not the patient I should be prescribing PO medications to. And that is something that may also violate the standard of care. Kind of going to your point, somebody is significantly depressed and, intractable depression where they probably need clinic or hospital treatment or something along those lines. And you prescribe something knowing that that is their condition and that they act on it, that also in itself may be outside the standard of care, especially if something bad were to happen. So again, it's a wider discussion. And again, I'm spending a little bit of time going into a little bit of detail because I know that a lot of questions are probably going to come around that. And even though everybody has 3 minutes, I'm hoping that by kind of explaining this from right now, that you guys have an understanding that this is not something that we're just being dismissive of, but I'm trying to help you understand the conundrum that we sometimes face when we're trying to, again, play whack-a-mole in other types of scenarios and how it can apply to other things, even other than ketamine in those types of scenarios, and how in those instances we have to also apply the standard of care, whether it's ketamine being prescribed orally or whether it's other medications that may have also sentinel effects that are being prescribed orally in those types of settings also. But under the OBA rules, this is what we're able to discuss right now. The others are going to have, again, a wider discussion and appropriate supervision and delegation of when the other things are being prescribed and making sure that the things that I described, where you may be prescribing to somebody inappropriately, who may not be of a sound mind, that they would not follow instructions and do something inappropriate, that again, may be something that even today we can act on. So anyway, hopefully that helps answer your question a little bit for right now. It's not exactly saying we're going to do all this today and tomorrow and be able to solve it. There are certain things that are very hard to solve and need a wider conversation, a wider discussion as a policy matter as to what we are willing to do as far as being overly prescriptive or appropriately prescriptive of what we allow physicians or other practitioners to do as we're trying to take care of our patients. You can't anticipate every single possible sentinel event that can happen and try to address it by law. Some of it just has to be a judgment call. We can oversee some of the judgment calls and make sure that it's being done appropriately. But it's hard to address every single one of them. We're trying to kind of capture at least what the appropriate standard of care is and apply that as we can.
Yeah, and I mean, I think you still are kind of conflating the prescribing versus administrating, like between the two a little bit. And I guess like I'm just confused because people keep bringing this to you of like, actually, here's the real problem. There's a huge loophole and people can get this, and they then are in control of a supply of it and having to self-administer and then still have all the airway risks that you're saying that you really care about that a doctor is on site for. So like, I'm just curious, like as people have continued to bring this up, we still are focusing on the regulations in clinic when this is like really where the issue, the abuse, the people not being fully informed, the risk is really at. And so I think like as we keep bringing that up, there's just different medications talked about. Like it's kind of just like, don't look at that. Like it's like that people are really saying like that's what needs attention.
Okay.
So.
All right, so your time is up, but I'll answer you, and I know that somebody else may want to come up and speak. So I'll just give another example. You can give IV Dilaudid. Dilaudid is another opioid. It's hydromorphone. IV Dilaudid has to be done in a certain setting. You can give PO Dilaudid, and PO Dilaudid is given in a different setting. It can be given to a person taking it at home. IV Dilaudid will act in minutes, and it can have a respiratory depressant impact in minutes. If I took Dilaudid at home, if I overdosed on it, it can also have, just like you described, respiratory depressant effect and so forth and so on. We regulate IV opioids or IV Dilaudid a certain way. PO Dilaudid, we put a lot of requirements on the prescribing practitioner to make sure that those that they are prescribing to are doing it appropriately, whether it's making sure that they don't have a risk of abusing the drug by making sure that they're using it appropriately, doing urine drug screens. I mean, there's a whole chapter on chronic pain management. Does there need to be a whole chapter on agents like ketamine? Probably, but we have to be given the legal authority to be able to do so, which we don't have right now. Kind of going back again to what I said that we need to do legislatively. But are there things that can be done and prescribed for people taking at home that can have bad things happen with them today outside of ketamine? Absolutely. And I'm using the opioids as an example because that's the clearest example out there. Mm-hmm. Now, to your point, the difference between PO Dilaudid and PO ketamine is that I can reverse PO Dilaudid with naloxone and or with Narcan. With ketamine, to the point that we've been making many times, is that it's not reversible because as an anesthetic agent, like propofol, like ketamine, all these other drugs, you can't reverse it. So it does have a safety profile that is much riskier than some of these other drugs, to your point. But to the extent of what we can regulate today, that's what we're doing, taking full recognition of what you're describing, that it needs to be addressed. And I'm going to kind of say it again. I've said it several times, but I implore you that when you see these things being done, let us know with some specifics so we can address it until all the other stuff happens. So we're not saying that we're going to be very dismissive of it. We're trying to let everybody know that there's a pathway for us to be able to appropriately investigate it to make sure that the appropriate standard of care is being met as it stands today with the rules today, understanding that more may need to be done. And that more that may need to be done probably needs to happen sooner rather than later. And we may look and see what we can do from our side, but at the end of the day, it may need to be a legislative function, which is 6 months from now or 5 months from now. And I know legislators are looking at it because they've called us and they've asked us and asked us what we think they should be addressing. So they've heard that loud and clear from us, and they may be hearing you guys talking right now and addressing your concerns that this needs to be addressed, and your advocacy to legislators that this needs to be addressed sooner rather than later, I think will be helpful also.
Mhm.
All right, thank you.
Thank you.
Yeah, I want to state your name. And again, this is a reminder for everybody that the purpose of today, right, is we're talking about PKT in a PKT practice and the requirements that are around that. So, I mean, it's not other types of medications. It's not other thing. It's just specific PKT in a PKT practice and what requirements are required for that. Registration, renewal, medical director, training, that kind of stuff. So if what's really gonna be helpful for the board today is getting comments of kind of like the first comments we got of like, I think there needs to be a physician on site for this reason. And the board can consider making that a requirement or not. Or I think that this needs to be added or this needs to be taken away, or you guys need to consider putting this in the rule, because we can't get into like a broader discussion or make broader changes about what this rule can or cannot do outside of PKT and a PKT practice. The recommendation can be don't pass any rule because we think there's loopholes that are going to be created for telemedicine companies. But the way I understand it now, those telemedicine companies are already doing these things that perhaps they shouldn't be doing. Some of them may be doing that. But this is specific again to PKT in a physical location. All right. Go ahead.
That's clarifying. It does sound like these newly proposed rules address some of what I'd like to comment on today, and I look forward to reading those rules. So I'm going to make some brief comments and follow up with a question. Thank you again to the board for your continued attention on this matter. This is obviously very important. There are risks involved, and that's what we're here to address. My name is Tim Geltz. I'm a licensed professional counselor associate, certified ketamine-assisted psychotherapist at Transcend. The main thing I want to talk to today is collaboration. PKT, or KAP as we call it, is a mental health treatment that involves a medical procedure. Because of that, safety requires both medical expertise and mental health expertise. I understand why the board is focused on medical safety, as this is the most paramount thing. But the decision about whether this treatment is appropriate for a person cannot be made well from only one professional lens. Medical professionals are best positioned to assess medical risk. The adverse events that you listed are obviously very important. Mental health professionals are best positioned to assess psychological and psychiatric risk, trauma history, dissociation, suicidality, untreated bipolar disorder, psychosis, schizophrenia spectrum concerns, readiness for treatment, and whether the treatment is actually serving the client's mental health goals. Those are not secondary issues. They are central to whether ketamine treatment is safe and appropriate. The best care happens when a medical team and the mental health team work together, each within our scope. The physician should not have to be the therapist. The therapist shouldn't pretend to be the physician. The patient needs both. I'm asking the board to preserve a team-based model, clear medical oversight, clear monitoring and emergency standards, and explicit recognition of licensed mental health professionals in screening, preparation, treatment planning, and integration. That's how we protect patients, requiring the right professionals to collaborate around the whole person. So my curiosity is, in these newly proposed rules, how does this address this new intersection between medical procedures and mental health practices that we're going to continue to see as psychedelic therapies become more prevalent, especially here in Texas, as it seems that we're leading the way in this in many ways?
All right. Well, hopefully this answers your question. I think maybe was it you that may have given us some comments before about allowing other mental health providers to kind of have that diagnosis, correct?
Yes.
Yeah. So again, thank you for that. We tried to incorporate. I think we even used some of the exact language you guys gave us. Yeah, in here. So we do talk about the psychiatric indications can have been originally diagnosed by a physician, an APRN, PA, or the other mental health providers that you gave the examples of which there's 1, 2, 3, 4, like six or seven of those. So that's kind of what we're looking at as far as the team-based piece of it. That could come from somewhere else, or they could be part of the team there, working with the physician and the practitioners and RN. But also the the medical director is going to have that requirement that he or she has the knowledge and the skill and the training that they could, if it's not coming from one of the mental health providers, that they and their teams can make that assessment and do it. And again, they'll be held to that standard.
You said if it's not coming from a mental health
Correct.
practitioner? Okay.
Right.
Okay.
If someone's just coming in brand new and saying, hey, I'm having these symptoms and this is kind of what's been going on, they may be able to make that initial diagnosis and say, hey, I think you're a good fit for PKT, or I don't think you're a good fit for it. But again, they're going to have from the board's perspective, the responsibility that you have that knowledge, skill, and training to make that assessment if it's not coming from a psychiatrist or some other mental health professional.
This is my curiosity. That I love the approach there. If a doctor is allowed to defer to a mental health practitioner, would they still be required to, say, have a CME around mental health diagnoses, or would they still just simply be able to take the word of someone who's certified within the state to get a diagnosis?
All of you guys are bringing up some very good points. What I would encourage you to do, because that initial diagnosis is actually a very important issue, and I get that, because you don't want somebody to just walk in and it's like, all right, you're this, and go ahead and get this treatment.
Right. Exactly.
I get that. Look at the rule. There is a portion in there that talks about how the initial diagnosis should be made. If you feel that there are gaps in there, we would love to get that feedback of what that looks like and how we can make it better. If you want to suggest CME, I mean, again, we can look at those suggestions and we can see what latitude we have to put that in there specifically, and kind of go from there. It may be that we can't change it the way it is, but what would be helpful is look at how we structured the initial diagnosis being done and what responsibility we're holding as far as a prior diagnosis made that we're utilizing versus the responsibility that we're putting on the medical director, and what requirements you think should be added onto that, and make that as a suggestion to us. Because looking at how we did that, we tried to make it as specific, but also as broad as possible. In other words, not being too prescriptive about it. But if there are gaps there that we don't see, because again, you guys are doing this every day, and if there's something there that we're missing that you think is very valuable, that could be additive, let us know in those comments, and we're more than happy to look at it in a little bit more detail.
Okay. With my remaining 15 seconds, the final thing I'd like to just bring up is risk, essentially. There are obviously physiological risks with any medical administration of any substance. What we see mostly in the mental health sphere is, say, suicide risk. If suicide risk is greater than the risk of, say, airway restriction from ketamine, what I would like to encourage is some sort of way that, say, the Texas Medical Board would be able to collaborate with, say, the Texas Behavioral Health Executive Council, that we can establish some sort of standard of, say, if the risk is present of airway restriction with the administration of ketamine, or cardiac risk from MDMA, or cardiac risk from Ibogaine, the risk of suicide through the assessment of a mental health practitioner is actually greater here. Therefore, the treatment may be warranted. As we're moving forward into the psychedelic space, there's going to be so much intersection between the mental health and medical side of things. And again, thank you again to the board for continued attention on this.
Yeah, and as you wrap up, let me just kind of say that in the adverse events, we did describe psychotropic events. And I would presume that suicide would be possibly a psychotropic event.
Certainly.
Now, even though we may not, and again, you can offer suggestions, but I think as we talk about that being there, that doesn't negate having some wider conversations to specifically describe how you define those adverse events. And that may involve collaboration with other entities. Again, those suggestions would be helpful, because even though we may not be able to put it in the rule, we can talk about how do we address that, whether it's in our FAQs, in collaborative efforts with others, guidance that, maybe, and that's important because that could be a pathway to our legislature, that if they were to put statute in place, here's a structure that we talked about, that we looked at, that may be useful in guiding how they put that into actual law, as opposed to a guidance from us. Okay?
Certainly.
Thank you
so much.
Yeah, thank you. All right, so I have 7 hands up. Let's see. Let's go with, okay, we'll try Carl.
Do you hear me okay?
Yes, we can.
I appreciate your time. Thank you so much. I'd like to make just 2 quick points. I appreciate the board's continued attention to this matter. The first one is it's been presented by some of my colleagues in the anesthesia community that there's no difference between sub-anesthetic and anesthetic ketamine, that the physician has to be present. I would just like once again to respectfully disagree with that. I'm a founding board member of the American Society of Ketamine Physicians, Psychotherapists, and Practitioners. We've been around since 2016. We have published various guidelines, a Delphi paper here recently that our organization does have anesthesiologists present. We do have emergency physicians, psychiatrists. So we would, I don't mean to speak for ASKP, but this organization and myself would disagree with the premise that we can't have a sub-anesthetic level of ketamine. We do use very low doses. The first clinics opened up in around 2010, give or take. So we have about 16 years of experience. There have been publications put out that I've referenced previously showing a very robust safety profile for outpatient psychotropic ketamine. So once again, I would suggest that a physician does not need to be present at the clinic for this to be done. A nurse practitioner, a PA, CRNA, perfectly capable of this. Related to that first point, I'm going to my second point is, again, in the United States, we have a very robust EMS system. I'm an emergency physician, over 20 years of practice experience, did an EMS fellowship. The EMS system in America could easily take care of, the kind of adverse reactions that we're talking about. The likelihood of airway collapse at the low doses we're using is very, very low. So I would think that the EMS system, the hospital system we have, is very appropriate for this. Now, when you make this new proposed rule saying that a physician has to either be able to basically beat EMS there or have privileges at a hospital, I think there's 2 problems with that. Number one is I'm looking at the published published data from Houston, for instance. The EMS response time is about 10 minutes, right? So a physician's gonna have to beat the ambulances. They got 10 minutes to meet your first criteria. So basically you need to be out in the parking lot making a phone call. Number 2, the idea of you have to be credentialed to help the treatment team with the management of a patient. I don't think that holds water. For instance, as an emergency physician, we would frequently have people who are traveling from other parts of the country who have complex medical issues. I'd simply call, if I'm seeing a patient who's traveling, to wherever from Cincinnati, and they have an oncologic issue, I'll say, hey, can I talk to your oncologist? I'd give them a call, we talk. That oncologist in Cincinnati does not have to have privileges at the hospital. The emergency physicians at that hospital are perfectly capable of taking care of the patients. And then, as has been previously stated, most hospitals now have a inpatient hospitalist service. It'll handle, if the eventuality is that they need to be admitted, can perfectly well handle that. A consulting physician does not have to have privileges at a hospital. So I respectfully submit that to the members of the board, that there's 2 issues here. One is, can you work with the treatment team to give them advice, whatever, on the ketamine? That can easily be done and is done all the time without the outside physicians necessarily having to have privileges at that facility. So with that, I'll cede my time. Thank you.
All right, we're going to go to the next one, but before we move on, because I know this is going to come up again, I think there's a general agreement in the medical community that physicians should be able to manage complications, or the typical complications of the treatment that they're prescribing, and I really have a little bit of an issue with just saying that, and Dr. Bhatia, who's a cardiovascular surgeon, makes this argument all the time, that physicians who prescribe or perform a therapy or a treatment and are not able to manage those complications, that's kind of an issue and a concerning issue. If I am an ER physician or a physician in a facility located next to a clinic, and I'm all of a sudden getting a whole bunch of patients that have adverse events at that clinic, but those who are prescribing the treatment are nowhere to be found or able to even collaborate on managing that patient, that's kind of like almost like dumping a patient onto me. I think there should be, as a matter of decency, the ability to help co-manage a patient that you've established a physician-patient relationship with, made a diagnosis on, probably understand that patient more than anybody else, and to not be involved in their care. Really what will end up happening at that point is they may end up getting a lot more done to them than they may need, or it may go in a direction that is unnecessary given that the person who knows the patient the most or should know the patient the most is not even involved in their care. So anyway, that's the viewpoint of the board from the standpoint of if you're going to manage a patient, you should be able to manage that patient even when there are complications. And that continues on when a known adverse event of the drug and that we've listed on here were to potentially happen. So with that is, who's next?
ME, is that? Mitchell Engel?
Good morning.
Morning.
I'm Dr. Mitch Engel. I'm president-elect of the Texas Pain Society, and I'm here representing them today. We already participated at the stakeholder meetings and submitted a formal letter of our comments as well. We have 4 very specific comments this morning. First, we support the comments of ASA and TSA at these meetings and previously at the stakeholder meetings. Second, we appreciate the initial dose inclusion in this version. We would also recommend a maximum dosage for PKT, as in over such a dose, the office-based anesthesia rules should apply. Third, we want to ensure that psychotropic ketamine therapy is specifically for the treatment of psychiatric.
Dr. Mitch, as you're doing it, can you suggest to us what that maximum dose should be as you're, or you can always submit it in comments later if you'd like.
Yes, I think that'd probably be the best place to submit that one.
Sorry, go ahead.
Third, we want to ensure that psychotropic ketamine therapy is specifically for the treatment of psychiatric conditions. Treatment of pain conditions would better fall under the office-based anesthesia guidelines, particularly since larger doses are traditionally used. And finally, we respectfully submit that governing PKT clinics under Chapter 172 of the Pain Management Clinic rules is a mismatch. We do urge the board, and I haven't heard the discussion this morning on it, to develop a distinct set of audit and inspection frameworks specifically for PKT clinics. Thank you.
Thank you. Appreciate that. Next, Dr. Prashad. Dr. Prashad, if you're there, you're still on mute.
Sorry, thank you so much.
There we go.
I just wanted to thank the board, and I'm so sorry I'm not able to get on the video right now, but I wanted to thank the board to continue to work on this. It's really, like I've said before, very important, and a lot of people are watching Texas, and I think we're getting closer to getting it right. I think the only thing I really wanted to add that I had concerns about was with regards to the hospital affiliation or privileges, just because, like, as a psychiatrist, like, I could get hospital privileges to admit to like a psychiatric floor, but I wouldn't necessarily be able to get privileges that would allow me to maybe help in a way if there was some kind of, cardiovascular event. So that was the part that I just wanted to clarify, that I think there could be some barriers in that regard based on the physician's specialty.
Yeah, just to answer that real quick. So we very deliberately did not say admitting privileges. But if you're a psychiatrist and that patient to the point where you can help manage the psychiatric conditions that may have led to this issue with the hospital in a collaborative fashion, I think that value is important. What we really are trying to get at with this is that we don't want this to be a hands-off thing where, I made an initial treatment, I prescribed this therapy, an adverse event happened, I'm hands-off, I have nothing to do with this. Having a collaborative effort at the hospital where, what you know about the patient can help manage that patient, I think there's a lot of value in that, as opposed to you get this patient, nothing about them, the person prescribing the treatment's nowhere to be found, and you're just kind of managing it de novo. And I think having the credentials at that facility where you can help co-manage or consult.
So what happens now is, like, if this kind of thing happens, like, it's usually not
that are set forth by the hospital's credentialing requirements, I think is something that's important.
Yeah, so what I was going to say is that right now, for example, let's say something similar happens, but it's not related to the ketamine or whatever. It's very common that I am still weighing in and helping the team collaborate on the care, even if I don't have privileges at the hospital, right? Like they're calling me, especially if the patient did get transferred from my clinic. So I guess my point is just that having the privileges doesn't necessarily guarantee that that you would or wouldn't be involved, right? Like I'm involved anyway.
Well, we're requiring that there
Right.
needs to be some involvement. So the problem is that you may be involved, whether you're somebody who's credentialed at the facility or not. But even if you're not credentialed at the facility, your ability to do certain things on a patient in the facility may be limited. We don't want physicians to be hands off. We don't want them to be 500 miles away and know nothing about what's going on and not be involved in their care. So if we're not going to mandate that they be 30 minutes away, which there's a lot of questions and concerns about that being a random number, then we do want to require them having hands-on ability to co-manage that patient in whatever way they need to in real time, not a day later, 2 days later, but in real time. Dr. You can go ahead and proceed, and then I'll let Dr. Green ask a question, but go ahead and finish your comments.
Sorry, I think I went on mute again. I was just going to ask if you had a sense of, the ability to get these affiliation agreements.
Well, these are things that are commonly done with surgery centers and with other entities. Whether it's an affiliation agreement or whether it's getting privileges at a facility, it's just like any physician getting privilege or having an affiliation agreement. I mean, it's just the process that you go through. That way, the hospital itself is aware that there's a clinic that may be doing certain things that may need their help in managing it. So from that standpoint, it's not like just, again, somebody randomly showing up the doorstep and like, okay, what do we do? And it helps them put some policies and guidelines that you, as a credentialed physician at that facility, would help outline. When you get a patient like this, unless it's an airway issue, maybe it's psychotropic, these are the things that we would like you to kind of help pay attention to that may need to be a focus. But we do want our physicians to be hands-on from that standpoint.
I saw, though, if you're present in the clinic, you don't necessarily have to have that. Is that correct?
No, we said that you have to be able to do one or the other in real time. So, you don't know on a moment's notice whether EMS is going to get there before you or anything like that. So I think you have to be able to do both.
Okay. Thank you for clarifying.
Okay. Are you done with your testimony?
Yes. Thank you so much.
Okay. Thank you. So I think next is Dr. Perry.
All right. Can you guys hear me?
Yes, we can.
Excellent. Dr. Zafran, Director Carlton, and members of the board, thank you very much for allowing me to speak to you guys today. I appreciate the board's willingness to take on this difficult issue. It's a place where access, innovation, and safety all have to be balanced carefully. Again, my name is Dr. Jeremy Perry. I'm a board certified anesthesiologist. I've been practicing for 19 years in Abilene, Texas, and I am speaking today on behalf of the Texas Society of Anesthesiologists, along with our 3,800 member physicians. One of my early assignments as a member of the TSA was working alongside now Representative Tom Oliverson when we provided major update to the state's office-based anesthesia statute back in 2012. I'd like to briefly address why Texas has the office-based anesthesia rules in the first place. The rules were not created in a vacuum. They were developed because potent anesthetic and sedating drugs, i.e. hypnotics, were being used outside hospitals where there was no facility standard, no monitoring requirement, and no adverse event reporting structure. That's the same problem you guys are facing today with outpatient ketamine clinics. Ketamine is not just another psychiatric medication. And in fact, under the same chapter which the new proposed rules are to take place, ketamine is specifically recognized as a hypnotic agent, the use of which requires a physician using it to meet the standards of a level 3 office-based anesthesia site. It can alter consciousness, impair airway reflexes, and create clinical conditions that require immediate rescue, and that's why it has that requirement. And my reading of the chapter is that as things currently stand, that is the standard that the Texas Medical Board is working under for the use of this medication outside the hospital. So hospitals and accredited facilities operate within a regulatory structure that emphasizes patient safety. They have credentialing, escalation pathways, and institutional accountability. Freestanding ketamine clinics currently do not, so we need something. We all agree that ketamine can be effective for psychiatric pathology, and we all agree that it can be done safely. The question is whether it should be administered in freestanding clinics with no enforceable safeguards. I think everybody here agrees that we do need enforceable safeguards. I urge the board to preserve strong guardrails, physician accountability, including appropriate on-site clinical oversight, continuous monitoring, affirmative reporting of serious adverse events rather than just keeping a log. Without these elements, Texas risks recreating the conditions and avoidable deaths that led to office-based anesthesia regulation in the first place. Thank you very much.
Thank you, Dr. Perry. And Dr. Green, I didn't forget about you, but one thing that we may need to clarify. So if you're physically, as a physician, present at the facility, there may not be a need for you to be credentialed at an affiliated facility. If you are not physically present at the facility, you are not at the facility, and it's a matter of either you responding before EMS or having that affiliation agreement or the credentialing at the hospital itself, that is different. So, but that's something that if it's not clear in the rules the way we propose it right now, we may clarify that. Dr. Green, did you have a question?
I was just going to say to Dr. Prashad and others that one can have courtesy privileges. So there's like full privileges, and we didn't really talk specifically about this, but courtesy privileges are sort of its own animal, and it's less onerous, you know, and sometimes you don't have to pay fees and stuff like that. But, and I'm sure, you know, most people are doing it right, and the privileges might seem like overkill, but this is for the people who would seek to maybe not do it right. And so having those privileges, as you said, makes a formal relationship so the hospital knows, hey, these are all the places near me that might be sending me this sort of emergency, and it's just much safer for the patient. And also the hospital can then sanction physicians who are privileged if, you know, they see bad things happening. So I just think that the hospital privileges is very important.
Thank you, Dr. Green. I think next is Dr. Duke.
Hey, good morning. I don't know why I can't get my camera to work. Do you guys have it on your end?
It's okay. We can hear you.
Okay, so good morning, and thank you for giving me the opportunity to speak with y'all. My name's Dr. Penelope Duke, and I'm a board-certified anesthesiologist of 30 years with 18 years in an office-based setting. And I might add that I helped with those guidelines in 2012 with Dr. Perry and Dr. Oliverson, and have been involved in office-based anesthesia for 18 years. So I appreciate what the board's trying to accomplish. It's difficult work, but it's vitally important that we get it right. Lives are literally at stake. I'll begin by sharing my why this issue is both near and dear to my heart, besides what I do clinically. My husband is a decorated combat veteran of both Gulf Wars. He risked his life for our country. I firmly believe all of our soldiers deserve the very best medical treatment for their battlefield injuries. This includes mental injuries from the battlefield, whose impacts last far longer and reach far wider than the wars that caused them. In our family, we've grieved the loss of far too many brothers in arms whose lives have been lost to substance use disorder and suicide over the years. It is in memory of these soldiers and in honor of these families that I stand here today advocating for responsible rules from the Texas Medical Board to guide safe ketamine treatment. Ketamine therapy has been marketed heavily to veterans as a treatment for PTSD. The concern is that some organizations appear to be giving a Schedule III controlled substance to vulnerable patients without fully appreciating the risks. During the stakeholder process, concern was raised about a patient who might be taking opioids and not disclose it. And I might add, sadly, this is a common occurrence in my own medical practice. Another commenter dismissively suggested that a patient could also be using cocaine, even in the parking lot prior to treatment. To me, this is not a joke or a hypothetical we can dismiss. The Veterans Administration estimates the lifetime prevalence of substance use disorders among veterans at greater than 50%. That means 1 out of every 2 vets. Studies show SUD, including opioids, increases substantially among combat veterans with PTSD. This does not stigmatize veterans. It means we owe them rules that take the risk seriously. Opioids and ketamine are safely managed together in a hospital environment because the patient is continuously monitored and rescued immediately in the event of an unusual or unexpected reaction. In a freestanding clinic with weaker oversight, that same combination can become dangerous or even worse, deadly. VA hospitals across the country have existing pathways and guidelines for ketamine therapy, literally for all veterans for free. Our guidelines should not be any lower than what the VA has already implemented for our vets. I'm here today to ask the board to establish solid guardrails through rules, including careful pretreatment screening, meaningful physician oversight, and immediate rescue capability. Veterans deserve access to promising treatments.
You'd wrap up, Dr. Duke.
Deserve to be vigilantly protected from avoidable harm. Thanks for allowing me to testify.
Thank you. Kenesha Muse, Dr. Muse.
Okay, good morning, Dr. Zafran and members. Thank you for allowing to testify today. My name is Dr. Kenesha Muse, and I'm a board-certified anesthesiologist with 6 years of clinical practice.
Someone will let me in. Here we go. Now we're in.
Oh, okay. I would like to address the practical clinical consequences of these proposed rules. There is no meaningful Texas precedent for allowing a recognized hypnotic anesthetic agent to be administered by IV, IM, or subcutaneous routes in an office setting without a physician physically present. That is not how these drugs are treated in Texas hospitals, and it's not how accreditation standards approach sedation and anesthesia. It should not come at the standard in a freestanding office where rescue capability is inherently more limited. It has been argued that during this process that healthcare providers administer medications under delegated authority in ICUs and hospitals. But hospital delegation occurs within a medical system that includes immediate physician availability, airway support, emergency equipment, multidisciplinary teams, and institutional accountability. A freestanding ketamine clinic is simply not the same environment. The dosing issues reinforces that point. Common PKT dosing substantially overlaps with published sedation and anesthesia literature. These are not trivial doses, and they should not be treated as though they carry trivial risk. Ketamine also has no antagonist or reversal agent. If a patient becomes more deeply sedated than intended, there is no medication that simply turns ketamine off. Rescue depends on that immediate recognition, airway management, hemodynamic support, continued monitoring, and experienced clinical judgment that the drug's effects resolves. Just as importantly, sedation is defined by the patient's response, not just the clinic's intent. No clinician can predict with certainty that the patient will experience no airway obstruction, apnea, laryngospasm, severe hypertension, emergency reaction, or other complications. Regulations should be written for the patient who unexpectedly requires rescue, not the patients whose course is uneventful. A physician participating only by telephone or telemedicine cannot open an obstructed airway, provide ventilation, perform a bedside assessment, or direct a rapid evolving emergency with the same effectiveness as a physician who's physically present. Ultimately, this rule is about establishing an appropriate standard of care. It is not about whether ketamine has therapeutic value. It is about ensuring that when a hypnotic anesthetic is administered parenterally in an office setting, the personnel and the physician oversight match the predictable clinical risk associated with that medication. I respectfully ask the board to recognize this clinical reality and preserve the long-standing precedent that parental hypnotic anesthetic drugs administered in an office setting require meaningful physician presence and immediate rescue capability. Thank you.
Thank you, Dr. Muse. Jack Swain.
Hi, thanks for the opportunity to speak today. My name is Jack Swain, and I'm the VP of Government Partnerships at MindBloom. We're one of the largest ketamine therapy providers in the US, and we've been providing treatment through telehealth for the past 6 years. Our patient data has generated one of the largest bodies of peer-reviewed evidence in the field, with 3 peer-reviewed studies covering over 15,000 patients. We understand the concerns around safety and would ask that you balance these concerns with the published body of peer-reviewed literature. We support regulation of at-home treatment, and we continue to offer to support the board with those efforts. We would also ask that at-home subcutaneous ketamine therapy be regulated like other at-home ketamine therapy treatments and not outright banned. 3 reasons for this are: 1, peer-reviewed literature around safety, which I'll talk more about, that many of our patients don't respond to or can't tolerate oral treatments and need a subcutaneous option, and the number of Texans who would be impacted today when this, or in 180 days when this ban goes into effect. So first, just on safety, we recently published a study of at-home subcutaneous ketamine therapy of nearly 4,000 patients who we've treated with this route of administration over the past few years. This study, which I'll reshare with the board and any others interested, shows an extremely low incidence of adverse events, and there were only 6 injection site injuries reported across the whole patient group. Generally minor pain, swelling, discomfort. There have been concerns raised by this group around respiratory issues. In the prior board meetings, stakeholder meetings, we've heard from other subanesthetic ketamine providers that they do not see these respiratory issues at subanesthetic doses, and our 3 peer-reviewed studies across more than 15,000 patients support that as well. As I mentioned, about some of our patients really do need subcutaneous, not just oral treatment. About a quarter of our patients don't respond to sublingual tablets, and when they switch to subcutaneous, over 60% then see clinically a meaningful improvement. And then third, this is a real access issue for Texans. We have over 800 Texas patients prescribed subcutaneous ketamine therapy, including 80 veterans. 96% of them live in mental health professional shortage areas. 50 live in rural counties. And for these patients, they will either lose access to treatment or be required to travel to a clinic or spend 3 times more on treatment per year. Thank you.
All right, thank you. Let me just note that for patients who are not able to take something PO, that the intranasal option is something that is out there. And even with that, I know there are concerns about doses or levels that would go high in those patients as well, even though they're administered in home settings. But you know, for those who can't take PO, there's already the option of intranasal. Anyway, next is Kristen Arden. Miss Arden, if you're there, you can unmute.
There we go.
All right, go ahead.
Okay, now you guys can hear me, hopefully. Hi, everybody. My name is Kristen Arden. I'm a psychiatric nurse practitioner and doctor of nursing. I'm the founding clinician and clinical director of MindBloom. I've been working in mental health for over 20 years, and I just want to say thank you so much for the opportunity to speak, for your collaboration and consideration of our comments. So at MindBloom, we have treated 9,000 individuals across the country with home-based, protocol-driven, telehealth-supported subcutaneous ketamine treatment, 1,000 of those individuals being Texans. I would like to speak about access to home-based PKT, a critical need for Texans, many of whom live in rural areas, as Jack mentioned. First, we support safety first rules for at-home care and would like to again suggest a carve out for subcutaneous ketamine at home in the current order so that we have the opportunity to reconvene on defining what safe at-home subcutaneous treatments look like. Our practice has transparently reported safety and adverse event data, most recently in a peer-reviewed safety and feasibility study with nearly 4,000 patients following our protocol, which demonstrated a serious adverse event rate less than 0.1%, and none of these serious adverse events were due to respiratory issues. Many of our patients need at-home subcutaneous treatment because tablets are either effective or intolerable. My positioning on intranasal ketamine being a replacement for these individuals is that intranasal ketamine, one of the challenges with it is proper dosing and a widely variable absorption of the medication based on the administration. So we currently have 300 Texas patients receiving at-home subcutaneous treatment at Mindbloom, and the order as written would restrict access to the treatment that these patients need. So we would really like the opportunity to address subcutaneous PKT separately, and we would welcome the opportunity to work with the board to maintain access and define what safe at-home care looks like. Thank you so much for your time today.
Thank you. Next is Amanda Woltering. Or actually, sorry, hold on. So actually, I think it's Michelle DeLeon. Ms. DeLeon, if you're there, if you could unmute.
All right, we'll come back to Michelle. We'll go ahead to Amanda.
Yes, hello. So yeah, thanks again for the opportunity to speak. I appreciate the board's collaboration, and I think it helps refine these rules to kind of maximize patient safety and also take into account other factors like access to care, feasibility and implementation, et cetera. I do have some questions though, just to kind of understand the rationale of some of these rules. My background is mostly emergency medicine, although I am a nurse practitioner with Transcend Health Solutions. But I worked for almost 2 decades now in emergency medicine as a paramedic and then emergency nurse practitioner. As far as the rule about the medical director needing to arrive before EMS, I'm just questioning the feasibility of that. I mean, the response time in Austin is around 10 minutes right now, and that's with an ambulance being able to use lights and sirens to bypass lights, and then also with ambulances being stationed strategically throughout the city to minimize the response time. So it just seems so unlikely that any medical director, especially when they're working full time, you know, not just available on standby, would be able to meet that requirement. I'm just curious what the board has to say about that.
Well, if the medical director's on the building across the street, they're going to be able to get there in a couple of minutes. If they're not, the word or I think helps address that, because the or part of it means that if they're not able to get there before EMS does, then they would go into that whole structure about the affiliation agreement or being credentialed at a local facility and so forth.
Yeah, so that takes me to my next question. So having worked in the ER, anytime a patient came in where it was like a very unique specialized situation, like for example, I remember one time I had someone come in with a post-operative complication from gender reassignment surgery. Not sure why they didn't just go to the hospital with the doctor that had privileges, but regardless, they ended up in my ER. So of course I had to call that surgeon because that's like a very unique situation that I didn't know how to manage. But what emergencies are you anticipating that the average ER provider, even like a mid-level or a physician, would have difficulty managing to the point that they'd have to consult the medical director of the clinic? Like what specific situations would warrant that?
All right. Well, in any management of a patient, if you don't have any kind of background as to what is going on with that patient, let's say they're having a seizure, and that seizure may be something that is new onset, and it needs aggressive treatment or an aggressive evaluation versus something that has happened, fairly frequently on a daily basis, and they know that it's going to go away in a couple of minutes. I'm just giving like a small example there, but the idea of managing a patient, whether it's in the ER, whether it's after the patient's admitted, after being stabilized in the ER, that at least you have a physician who is credentialed and is able to participate and collaborate in the care that is being done with that particular patient. The idea behind that is that we don't want physicians to be hands-off in the management of patients that they've already established a physician-patient relationship with, diagnosed with, and have diagnosed and prescribed therapy for them. So if we're not going to require a physician to be physically present at the clinic while this stuff is being administered, our feeling is that at a minimum, they should help manage adverse events if and when they happen.
Yeah.
And
so
I think you have 58 seconds more in your testimony.
Okay. So I understand the rationale and I appreciate that the board's trying to prevent these like very hands-off medical directors. But having worked as an ER provider, I can tell you if someone came in with, first of all, EMS is going to tell you the history. So they're going to pick up the patient from the ketamine clinic. They're going to say, here's the background. The patient just got ketamine, right? Like they're going to have the history. They don't need to call the medical director. The medical director is probably not going to know. They're probably going to be on shift, not having access to that EMR. Like they're
So
going
you
to
said
go off
something there that
EMS's
actually
history.
strikes me as scary. The medical director would not know. We want the
Yeah.
medical director to know, or the
Well, and
physician
so-
that they delegated to know. That's
Yeah,
a
and
big part of
I
the reason
appreci-
behind all this.
Yeah. And like I said, I appreciate that this is the board's intention for that rule. And I do think that's a problem that needs to be addressed. However, having worked in the ER, I can tell you if someone came in with, think of all the ketamine emergencies, laryngospasm, respiratory depression, aspiration, hypertensive emergency, arrhythmias, that is all managed by a standard ER provider. No ER provider is going to call the medical director of a clinic and say, hey, I have this. It's just not going to happen. Like, I don't know if anyone on your board has worked in the ER and their opinion on this, but I can tell you, no one's going to do that. They're only going to call for post-operative patients, really unique, specialized situations. So I think although the intention of this rule is great, I agree that that's a problem, these really detached medical directors. I think it can be addressed in a way that doesn't limit access to care, because that's going to make it harder for clinics to
If you could wrap
have.
up.
Yep. So that's going to make it harder for clinics to have a medical director that has to have privileges, has to respond before EMS. So I would just urge the board to maybe try to reconsider other ways to address that problem.
Okay, thank you. Before I go to the next one, so I'm not an ER physician, but I work in a trauma hospital where we get patients who come in quite a bit of time into the ER in multiple different hospitals. And very frequently, when you have a patient that's coming in from the street, that's one thing. But if you have a patient that's being transferred from a facility or from a clinic, or somebody that had a complication somewhere, whatever that might be, that is being managed by or directed by a physician, we always get a call, usually ahead of time, by that clinic or by that office saying, we are getting a patient over to you. Here's what happened. They're coming over to have their care addressed by you. So that is not an uncommon thing. That happens very, very frequently. All right, with that, I believe Deborah Plagenhoff, Dr. Plagenhoff, you're next.
Yeah, you may be on mute still.
Okay, go ahead and proceed.
Hi, can y'all hear me now?
Yeah. Yes, we can.
Yes, I'm sorry, I just had to pull over for that. Got it. No, 1 second, I'm ready. Okay, Dr. Zafran and members, thank you for the opportunity to testify. My name is Dr. Debbie Plaganoff, and I'm a board-certified anesthesiologist. I want to focus on one specific issue, adverse event reporting. The current draft appears to require clinics to keep an adverse event log and then allow the board to periodically request and review that information. That is a start, but it is not enough. For a new area of practice like outpatient ketamine therapy, passive collection is not a safety system. If serious events sit inside clinic files until someone asks for them, the board will not know whether patients are requiring EMS transport, airway rescue, or hospitalization. The rule should also require 24-hour follow-up with the patient after treatment. Some complications may not be fully apparent at discharge. A patient may later present to an emergency department with hypertension, altered mental status, psychiatric distress, or another treatment-related concern. If a patient presents to an emergency department within 24 hours of ketamine treatment, that should trigger required reporting to the board. The clinic should not be able to avoid reporting simply because the patient deteriorated after leaving the facility. That approach is consistent with how Texas has treated other office-based sedation and anesthesia risks. In office-based anesthesia, serious transfers, hospitalizations, and deaths are reportable to the board. The dental board also uses affirmative reporting for serious anesthesia-related outcomes. A log is useful, but it cannot be the whole system. The rule should require internal documentation, 24-hour patient follow-up, and affirmative reporting within a defined time period. That is not punitive. It is how a regulator learns whether its safety rules are protecting patients. I urge the board to make adverse event reporting proactive rather than passive. I would also make, as a last comment, a comment regarding the testimony of the last person testifying, and that is my personal experience of being in an office-based setting with a patient waking up from a propofol anesthetic, and the patient had eaten inappropriately, vomited, and the EMS system came with their medical director directing them to take the patient to the hospital so I could check and make sure the patient hadn't aspirated. At that point in time, the patient was in emergency delirium, and the medical director, or the emergency physician directing the paramedics, directed them to give that patient ketamine to, quote, calm him down. I intervened as the attending physician, knowing the history and knowing what was going on with the patient at that moment in time, and stopped that ketamine from being administered to that patient, and therefore sedating him further, and therefore putting him at increased risk of aspiration. So as to the comment of whether the attending physician or a physician that knows the history of the patient is relevant, it is very relevant. Thank you.
Thank you, Dr. Plagenhoff. Dr. Green, you're going to talk and discuss as a board member, unless you have something specific that you want to make a comment as far as anything that was already said.
Yes, I just had a comment along the same vein as Dr. Plagenhoff. So unfortunately and tragically, people stroll into the ophthalmology clinic having heart attacks and strokes, which is terrifying for us ophthalmologists, of course. But when I send that patient, with the paramedics, of course, I talk to the paramedics, but I call the ER. I don't wait for the emergency medicine physician to call me, because I have the patient's med list. I know the patient so much better than anyone except for their primary care doctor, medically speaking, probably. So it's really our duty as physicians and our duty to our patients to do that. And so I think it's fully appropriate for us to do that, and for it to be, in the structure of these rules, for that to be fostered.
Thank you, Dr. Green. All right, next is Michelle De Leon.
Hello, thank you for the ability to ask some questions about the proposed rules. The first question I have is around the credentialing for the physician at the hospital. So,
could you let us know who you are first?
Yes, my name is Michelle De Leon. I'm a nurse practitioner with Illuma Ketamine Clinic in Austin. So, for example, I would like to first know if there is rules or the same precedent applied to other clinics where there are risks for adverse reactions. For example, chronic pain clinics that may or may not provide ketamine, dialysis clinics where commonly adverse reactions happen and those patients have to be transferred to the hospital. Is there a precedent for them to have that same requirement for credentialing for collaboration of care once the patient gets to the hospital?
So the immediate precedent that I'll tell you is actually by the law passed in Georgia, specifically around ketamine, where that requirement is actually there. So as states are looking at putting forth regulation around this, that is becoming a standard. What I will tell you is that there is a common requirement that in facilities where procedures are being done in general, that there are these affiliation agreements that are in place to make sure that patients who are being transferred for a level of care secondary to an adverse event, that those physicians may have to be able to or should have to be able to manage those. I know there's a lot of controversy that happened with one specific law that passed, and this was prior to the abortion law, where there was a mandate for those providers also to be credentialed at the facility if there was some kind of adverse event to the patient that an abortion was being performed on. Now, that was challenged in court prior to Roe v. Wade being rescinded, but that requirement was there. It was rescinded primarily because it felt that it was a limitation on those patients managing or being able to get treatment but it was challenged, and I believe that it was looked at differently. But in general, and again, my lawyers can weigh in, that there is a general requirement that if you are performing a procedure somewhere, that you have an affiliation agreement or direct ability to help manage that patient in a facility that patient's being transferred to.
And that's currently in the state of Texas across facilities where there are risks for adverse events.
Hey, Scott, do you want to talk again some about how we do this with OBA? I mean, I know this is under the OBA rule, but as far as like the emergency plan for in the case of an adverse event.
And remember the difference with OBA here also is that there is a physician physically present there. So that's the big deal. When a physician's physically present there in this rule, we're not requiring a person to be credentialed at that facility. The or part of it is where we require that. So that's the nuance that's different here. But the requirement is not there if the physician is physically present at the facility where the administration is being done. Sorry, Scott, go ahead.
No, I was just going to say that in any and all settings, we have some form or another of how emergencies are supposed to be responded to. So it is not an unusual requirement in any rule.
Thanks, Scott. And like I said, I would like to reiterate, there's an or in there. If we're going to take away the requirement of a physician to be able to either be physically present or able to respond in a very specific timeline, that's where that applies. So again, just want to make sure that that is clearly understood. I think you still have 1:58 left if you want to continue.
Yes, please. My follow-up question to that is, in my instance, my medical director is a full-time anesthesiologist, and he is at a hospital that's in close proximity to our clinic. If we were to transfer a patient there, he has credentials. However, if he's currently working on another patient case, would that not constitute patient abandonment of the patient case that he's currently working on to then go to the emergency room and collaborate with whatever needs to be collaborated on the transfer patient?
Can I jump in here for a minute, Dr. Zafran? And I appreciate, the questions that are being asked here, about how would this apply, how this doesn't apply, how it might apply. And these are all very good questions. But again, I think rather than saying in this specific scenario what would happen today, and Dr. Zafran can respond, these are the kind of comments we want, because remember, if the board votes on this today and approves it, there's at least another 30-day comment period to look at these things. So again, I think we have to be mindful. We want to hear what the concerns are, and I think what you're expressing here is a very good question, but to necessarily seek specific response and say, well, I'm going to give you scenario 1, what would happen? I'm going to give you scenario 2, what would happen? Scenario 3, what would happen? I think what we need is those to come in the comments, but I don't think it's really the place necessarily to ask specific scenarios right here. As Dr. Zafran has explained and explained several times, and I don't want to cut off commenters, but this is what they're setting up to respond to particular emergencies. And you're saying, well, what if my physician's occupied? I think I know what Dr. Zafran is going to say, and I'll let him say it. Well, there's a medical director. There may be other providers at that clinic approved. But again, remember, our scope here today is not necessarily to answer each and every question, but to say, does the board think this generally work in a way that protects patients and preserves access? These specific scenarios are perfect, I believe, more so for comment. Now, Dr. Zafran can certainly answer them, but again, I caution you that we've had 2 or 3 speakers say, well, in my experience, this happened, and then this happened. The next speaker comes up and says, well, what about this? Or I've seen this. But again, we get those things happen in the real world. We want to know about them, but to continue to ask very specific scenarios and expect very specific answers, that's really not the intent of this particular forum.
Thank you, Scott. I will answer this question, but then as Mr. Freshour said, let's try to make the comments a little bit more general. What we said is that very specifically that the physician has to be available at the facility per the credentialing requirements in order to be able to help manage that patient. Now, some hospitals, when a patient of theirs gets admitted, they require them to be there within the first 2 hours or within the first 4 hours. The patient's already being managed in the ER. Initially, there, as Dr. Green said, there really should be a communication between the physician and the ER to kind of help explain what's going on. But the initial management may happen in the ER. The patient may get admitted. But there's an expectation that at some point, per the requirements of that facility, that physician who's credentialed there needs to be able to help manage that patient at some point within the requirements of the facility itself. So, we have surgeons who are working at a surgery center and their patient may have a complication that gets transferred. They communicate with the ER, let them know, but they have to finish their other surgery. And the patient may have had a complication in recovery and they're still operating on their next patient. They're not going to abandon that patient, leave and go over to the hospital, even though that may be their expectation to help manage that patient afterwards. So again, these are all nuances. I think we address this in a fairly broad way to help address that. It may not be as evident, and that's why the comments that you send in writing can help answer that. But with that, you have an additional minute and 27 seconds to go.
Okay, thank you. To follow up on that, certainly a phone call to the emergency room or wherever you're transferring to from the transferring clinic is certainly warranted. I mean, I worked in urgent care where that was our standard. But, Dr. Green, I doubt, is credentialed at whatever facility she'd be sending patients to, and other physicians for that matter. So is there some sort of way to incorporate a requirement that, yes, we are having a conversation with the receiving facility, but not generally apply a credentialing requirement, because that's certainly not going to be the case across other specialties where complications might happen?
Yeah. So, I mean, again, I think for like Mr. Freshour was just saying, what's helpful is for you to give like what is your recommendation of what you want the board to consider today. And so if generally your comment is, I think the requirement of having privileges at a local facility is too onerous, or it is infeasible, or it's not going to be helpful, you say in the alternative, the board should require that the physician, the medical director, or the physician that's responsible for that day has a documented communication with the emergency physician that receives the patient and has follow-up communication upon the patient being stabilized. So that's the recommendation I'd like the board to consider as far as a change to the rule. Is that kind of along the lines of what you're getting at?
Yeah, I mean, I think that's very doable to provide that recommendation.
Okay, and then the board can obviously take that feedback, and then the board can debate amongst themselves of whether or not they want to make that change or leave it as is, as far as what's going to go forward in the if they move forward with it to go out for public comment. Are there other comments, or was it?
Yeah, actually, Dr. Green, I think wanted to make a quick comment.
Okay.
I still have a minute.
Yeah,
I know you have 38 seconds, but Dr. Green wants to make a comment. She's a board member.
I'm actually credentialed at both local hospitals in my rural area.
Okay.
All right, thanks. You have 38 seconds left.
I'm just curious when the new proposed rules will be available. I'm not able to find them on the website.
Once they be available after the board, assuming they approve them today, whatever version that is, staff has to get them prepared and sent out, I believe today, to get into the register so that they go in by next week. So we do kind of have a hard cutoff here of we need to kind of have this kind of done by noon because we're working on a tight timeline with the holidays coming up and the time before the board meeting in August.
Okay, I appreciate you guys hearing me out. Thank you for the time.
Absolutely.
Thank you. Dr. Ablache.
Hi, good morning. Dr. Zafran, members of the board, thank you for the opportunity to speak. I am a board-certified anesthesiologist practicing in Texas for over 30 years. I appreciate the time the board has given to all sides of this issue and the seriousness with which you're approaching patient safety. Before I begin my comments on the proposed ketamine rule, I do have one question. Instead of limiting the requirements to ketamine alone, should the board consider applying them to any parental medication used for psychiatric therapy? This would establish a consistent patient safety standard and prevent the need to revisit this every time a new parental medication is used off-label for psychiatric purposes. I'm going to pause to see if that question can be answered.
Well, to Mr. Freshour's point, I'm going to be careful about answering every single question, but I think the difference here compared to any type of psychiatric medication is that this is classified by the FDA as an anesthetic agent, and it's irreversible. So I think, to your point, if propofol is being utilized, maybe there's a comment that you may be able to put in that it may need to be involving other types of anesthetic agents or what have you. But in general, I think we're looking at this differently from any type of psychiatric drug in general because it's classified as an anesthetic and it's irreversible.
Thank you. Definitely in our comment letter, we'll ask, should this be any anesthetic agent, classified anesthetic agent? Thank you. The issue before the board today is not whether ketamine has an appropriate role in patient care. It does. The board's mission is to safeguard the public and patients in the practice of medicine. Because parental ketamine is a medication capable of causing loss of protective reflexes, airway compromise, or cardiovascular instability. Parental ketamine is the practice of medicine. I want to address the issues most likely to matter in this proposed rule. First, physician presence matters. A physician who is available only by audio or video is not equivalent to a physician at the bedside when a patient develops airway obstruction, severe hypertension, aspiration, agitation, or prolonged recovery. These situations require immediate medical judgment, at times immediate intervention. Second, monitoring must be continuous. If ketamine is administered in multiple treatment rooms, every patient should have a qualified individual continuously dedicated to monitoring that patient. A floating model is not continuously monitoring. When a patient becomes more deeply sedated than intended, delays are measured in seconds, not minutes. Third, the board needs meaningful outcome data. Internal logs alone cannot tell you whether these rules are protecting patients. If a patient requires airway intervention, EMS transportation, hospitalization, or presents to the emergency department within 24 hours of treatment, that event should be reported to the board within a defined time frame. Without objective reporting, there is no reliable way to evaluate whether regulations are working. Fourth, the board's duty is to protect patients, not business models. If a practice cannot safely provide parental ketamine under proper physician oversight because of cost, then that business model, rather than the safety standard, must change. Finally, the rule should require physician accountability. If ketamine therapy is the practice of medicine, a physician listed on the registration must have actual authority over patient selection, dose, delegation, emergency response, discharge criteria, and the ability to stop unsafe practices. Paper supervision is not medical supervision. The board does not need to prohibit ketamine therapy. It needs to ensure that it is practiced safely. I respectfully urge you to adopt rules requiring meaningful on-site physician presence, continuous patient monitoring, proactive adverse event reporting, and genuine physician responsibility for medical care being provided. Thank you for your consideration.
Thank you. All right, Aaron Amato.
Good morning, Mr. Chairman and members of the board. My name is Dr. Erin Amato, and I'm a physician board member representing ASKP3. And I appreciate the opportunity to speak today on behalf of the American Society of Ketamine Physicians, Psychotherapists, and Practitioners. I simply want to thank the board and staff for the significant work that has gone into developing these rules. We appreciate the thoughtful process and the board's willingness to consider stakeholder input. ASKP3 encourages the board to move forward with adopting this rule. It is important that physicians and clinics have a clear regulatory framework so they can continue providing care with confidence rather than operating under uncertainty. No regulatory framework is perfect, and as the science evolves and experience is gained, future refinements can always be considered by this board or, if appropriate, the legislature. Finally, Dr. Sandhya Prasad regrets she had to jump off the call. She asked me to let the board know that ASKP3 remains available as a clinical and technical resource as these rules are implemented. Thank you for your time and for your commitment to Texas patients.
Thank you. Thank you for your input. And right now, I don't see any other hands raised. So if you would like to speak, please raise your hand so we can recognize you. Okay. I think with that, we will go ahead and close the public comment period. And we will go ahead and move to discussion with the board. So board members, before you is proposed rules regarding the administration of ketamine under Chapter 170, under Chapter 173. You've heard public comment. I'm going to open it up now for discussion. So with that, I see Dr. Jones, your hand's up. Go ahead.
Thank you. I had a couple of very quick kind of housekeeping requests just to get off the kind of docket that I don't think changed any of this whatsoever, but might clarify a little bit. First, in the definitions section, under subsection G for practitioner, the definition of practitioner, I think we should just simply list that before section F. Basically, trade sections G and F have practitioner defined before we use that word in its defined state. In section F, which is the psychotropic ketamine therapy, just simply for a little clarification. And then the other request is, I notice that to be very clear and legally proper, we're saying under delegated authority, and I think it's written very well. There's a few instances where we're using the phrase practitioner with physician-patient relationship, and I understand that every time that is used, the inference is that that's under the delegated authority that's appropriate for that practitioner. So I would ask that anytime it's used in that setting, which I have, I think, 2 of them here, maybe 3, that we simply just use the phrase, under delegatory authority after the word practitioner. And so the first example is on page 2, line 6. It just says any physician or practitioner. And then I would use the phrase under delegatory authority. And then the next one is on page 5, line 1. After the word practitioner, just the phrase under delegatory authority. And then the last one is on that same page 5, line, 1, 2, 3, 8. That'd be the beginning sentence of section 4 on page 5. After the word practitioner, I would just write under delegatory authority, just so that it's clear every time kind of how it's set up, because sometimes it looks a little confusing when it says the practitioner and the physician-patient relationship, when the practitioner by definition is not a physician, but is under delegatory authority of one. Just kind of wanted to get those out there as simple housekeeping type changes, if you think those are reasonable.
That was actually the intent. So thanks for catching those 2 or 3 that didn't have that on there. And I think from my standpoint, I think that's an appropriate just add on, unless I'm missing something that.
Can you turn on your mic, Dr. Zafran?
Sorry?
Your mic.
Sorry, go ahead. Oh, yeah. So no, what I was saying is that was actually our intent, is to have it after all those areas, just to make that clear. So thanks for catching a couple of those that we didn't have that specifically on there. I think those are editorial ads that
Sure.
that just helps clarify things. The order of things, it's typically by alphabetical order, but I think your point about one going before the other, just to help make that clear, I think is appropriate. It doesn't really change anything, but it helps at least clarify, in order of how it appears on there. So I personally don't have a problem with that.
Well, just let me jump in on that. On the first one, the register makes it go in alphabetical So that we can't change. Some of this is formatting. So that one, we hear you, but we know they're going to kick it back on us, so we're not going to do it, Dr. Jones. Sorry. The other ones we can certainly look at.
Sounds good. And then I have one other comment too on that page, on the page 2 of the definitions, which is under the
Yeah, but just before you say that, Zach.
Yeah.
So it's PR, so it really should be above it anyway, Scott. So either way, it should go above it regardless.
You're right, actually, Doc. I was just looking at that. You're right. I had to go through ABC, but I think we've got it there. So no worries.
All right. No need to even ask. Okay. And then one other thing on that, in that same area with the definitions under section F, currently the psychotropic ketamine therapy, on the second line there, this is on page 2. It lists a few psychiatric diagnoses and it says indications such as, so that to me says this is not an exhaustive list, but just a few examples. My question is, since we are really trying to focus on the involvement of the physician here, and that we want there to be a diagnosis of some sort that's been appropriately made by either a physician or another licensed healthcare professional, are we requiring this diagnosis to have a CPT code? Because certain ketamine therapy is now being advertised for things like burnout and other conditions that are not necessarily medically diagnosed conditions. Are we now excluding those
No,
things?
Zach, I think it would be appropriate actually to add in there such as, but not limited to.
Okay. And then the second part is, how specific are we getting with medical diagnosis? Because we do come across this in other areas as well, where it's, something like adrenal fatigue, where it might not be a CPT code. However, it's an accepted phrase in certain treatments. So that's one thing is with ketamine, I see it more and more inclusion of conditions that may not be considered a medical diagnosis.
So that kind of goes back to the whole standard of care issue, right? So rather than being overly prescriptive on it, and again, this is open for debate. So just because I said it doesn't mean that we can't have that conversation around it. But if we were to get a complaint about something that involves treatment that may sound inappropriate, and our ASKP physicians could help weigh in on that also. But if we were to get a complaint and we sent it out to our expert panelists that presumably would be psychiatrists, they would presumably be able to let us know whether that is appropriately part of the standard of care or not. So, again, there's some, I think if we get too prescriptive on it, we're going to have a problem. I think if we overly make it broad, it's going to be problematic. I think that's why there's a such as, and probably, adding but not limited to. But we've got to at some point also leave it broad enough to discretion. There's some medical judgment involved there, and then we can leave it to our expert panelists when complaints come in as to whether it does meet the standard of care or not. But again, it's open to conversation and debate between the board members.
Sounds good. That was, I think, mainly it. I did like actually some of the idea with the affirmative reporting instead of the passive reporting for adverse events, especially in a new field like this where it's difficult for us to find out adverse events unless we're kind of searching for them, which we don't typically do. And that other modalities using anesthetic agents are using an affirmative reporting approach. I think that would heighten patient safety. And so I think that's potentially a good addition to strengthen these, but not make it overly onerous. However, like you and I know, if you're at a surgery center and you have a patient who has an adverse event requiring EMS transport, that's a reportable event that then gets sent to agencies so that how many of those are happening with what frequency, and then that could lead to changes in that process to make greater patient safety. So I did actually appreciate those comments. I think that those would be helpful in this.
Okay, Mr. Kokonos, you had your hand up earlier. Did you accidentally put it down, or you? I know, Dr. Naidu, I saw your hand up, but Mr. Kokonos had it up a second ago. I just want to make sure that he didn't inadvertently put his hand down.
I didn't put it down. The original draft we're talking about right now has been removed. Is that what you said, or?
So the vote that we took earlier removed the earlier draft, And now before us is consideration of this draft alone.
And this is another draft? Or is this a rule?
Well, this is a proposed rule now for us to debate and discuss and contemplate edits and vote on, and consider for adoption later today.
And this would go back, out for another minimum 30-day public comment period.
Okay. Okay. Thank you, Dr. Zafran, Brent.
Sure. Yep. Dr. Naidoo?
I just want to know whether do we have any detailed consent from the patient? Do we do anything about consent form? What are the complications? What the patient should know with this treatment?
So we do talk, and Scott's bringing up the exact area. Go ahead. Sorry, Brent's bringing up the exact area. Go ahead, Brent.
So what it says is, I mean, you always have to do informed consent, but we do specifically outline in here, in addition to that, it must include a discussion of known risks of PKT, the identity and licensure credentials of the person administering PKT to the patient, and the person delegating to that person, if it's not a physician, if applicable. And then also talks about the pregnancy test or written affirmation, and then the timeout period. So there's the normal informed consent that you have, but we also put in there specifically, it has to include the known risk of PKT and who's going to be administering and who's delegating to that person, if so.
And that insinuates also the adverse events that we listed above as being things that need to be discussed in the consent. Any other questions or comments by board members? Brent, did you want to just address the issue about affirmative reporting versus passive reporting?
Yeah, I mean, part of it is a resource issue, right? So, if we're getting affirmative, like, hey, this is an adverse event that happened at this clinic, and we're just proactively sending it to you. I mean, for staff purposes, like, is that going to trigger an investigation for every adverse event that comes? Or are we going to, kind of as the rule contemplates right now, we're going to get that adverse event log whenever they renew and review it for trends or things that have gone on during that 2-year period. I mean, staff already has close to 10,000 complaints that we're getting a year as of right now. There's just kind of a realistic expectation of, if we're getting all of these proactively, and who knows, maybe it's not very many. I mean, ideally, there's very, very few. But if we're getting a lot every time that, someone is transported or something, it's like, are staff going to really have the our big monitors keep going in and out, but we've got you on the small screen here. So it looks like it's being.
I guess one thing I would add, though, I think that in facilities, when a patient specifically gets transferred to another facility, that does get reported to the Department of Health. I think if you have an adverse event that you're able to manage and treat at the facility versus an adverse event that requires transfer to a higher level of care, maybe there's a distinction there. And again, I'm just kind of throwing that out there for comment. Do we treat that differently? I mean, just because somebody had like an airway issue, but it was appropriately managed and dealt with and nothing came of it, or a patient had a seizure and they're able to manage it with the medications they had on site and be able to deal with it, versus if you had something that required the patient to be transferred to a hospital, should we treat those two differently and say, well, that one should be reviewed. This one we'll obviously see when we get the report every 2 years of the log and so forth. So just wondering what y'all think about that. And I think Dr. Green, you're next.
I think it's potentially challenging to come up with, because I'm just imagining, I've had to send patients obviously from my ASC to hospitals over the years, not often, as Brent said, Mr. Carlson. But like, I'm thinking of like, if the nursing staff, they would have to have like a very specific set of when to report. Otherwise they're going to be like, oh no, are we in violation? Do we need to report? Are they going to over report? Like, what exactly do they need to report if the patient stays in the house and is managed without transfer? I think that could be challenging.
All right, Dr. Jones.
I think that's a great idea, Dr. Zafran. The differentiator is, did they need to be transferred via EMS? Hopefully, as Brent mentioned, that's not a common occurrence. I'd like to think it's not. I know with my work at surgery centers, it's not a common occurrence, but when it happens, it's a fairly severe, significant event. And if, unfortunately, they are more frequent than we had intended, then that could lead us to keep a sharper eye on some facilities. I also think that enhances our physician responsibility to their patient. I know that we talked a lot during the comment period about, credentialing for physicians who are the, prescribing or treating physician. And, like Dr. Green mentioned, I have credentials at the neighboring hospital to surgery centers I work at. And, a lot of complaints we get from patients are due to communication lapses. And that's a big one, is when you have a bad event and then the doctor that was involved in that treatment kind of, isn't as involved. And I think that the ability to do that is a big deal. And even if it's just simply going in and doing a social visit because the ER did appropriately manage things, that actually does go a long way. But that's, sorry, going on a tangent. I do think that EMS transport is a very valid kind of differentiator. And I'd like to think that it wouldn't overstress our already well-worked staff who do a great job.
Yeah, but I think, Zach, to your point, it may highlight the importance of recognizing a specific clinic that may be having issues that may need to be looked at, and doing it sooner rather than later, not waiting until more events may happen. So, how would we add that in there if we wanted to, Brent?
Good question. So we'd have to find a spot to add in, because you're not saying they have to proactively report every adverse event. It'd be only when they're transported by EMS.
No. We're saying that you have to report all adverse events in the law, but what we're saying is that when it is an adverse event that requires transport by EMS to a facility, that needs to be an affirmative report to the board.
That's what I mean. A proactive, the clinic needs to notify us within, whatever time period, 24 hours, 1 week, like whatever you guys decide. You're saying you want them to let us know, hey, I had a patient that was transported to an emergency room by ambulance or whatever means they got there. And I guess that's only if they're reported, if they go from the clinic to the ER, not if they get home and then go to the ER, or, I mean, kind of what do those parameters look like?
Well, if you follow the facility standards, like surgery centers and all that, my understanding is that if they're directly transferred from a facility to the hospital is when it triggers a report, because then you're going to get into the issue of, well, if it's within 24 hours, if it's within 48 hours, I think it would be good to know those eventually, but maybe at least at a minimum, the affirmative reporting, just to make it simple, is that if you have a direct transfer from the clinic to, or whatever that facility is, to by EMS to a facility, which is an emergency room.
And those exist for office-based anesthesia, and it's a 15-day period that the surgeon or other physician has. And like you said, Dr. Zafran, it's titled unanticipated transfer / hospitalization or death. So we already have that language for the OBA rules, and it's 15 days.
Just a second. Okay. We'd probably have to stick that in the, I guess, what do you think, Scott, in the operations section of a PKT clinic? And we'd have to craft some additional language to go in there. Now, I guess, are we wanting them just to say, this is the patient that was transferred on this day and time? Or are we wanting them to, I mean, essentially, by reporting it, it's almost triggering a complaint.
I think they need to at least, put some kind of
themselves.
some kind of idea of what happened. You know, a brief description of this patient was transferred. Here are the circumstances behind it, and just that way we kind of have at least a little bit of an idea.
Yeah, and I think we could gather the information. And
Yeah.
again, part of this goes to both,
Yeah.
every stakeholder and you as a board have all said, and one of the thoughts was when we were putting in this reporting is you need the statistics, you need the information, you need to know what's going out there, and you don't know it right now. So if we have that, we can, I think, as Dr. Jones said on that, Mr. Carlton, I think we can use some of the OBA language perhaps for, you know, reporting the unanticipated.
Hey, Scott, you're muted
Scott,
now.
you're muted somehow.
I'm sorry about that.
There you
What I was saying is, you know, part of this is, I think first off, we can take some of the model from the OBA, as Dr. Jones was indicating, probably modify it for, you know, unanticipated immediate transfers by EMS from a clinic. The idea behind this and the whole adverse reporting and why we wanted to gather it, you know, at each registration is the idea that everybody was saying, you know, from board members to all of the speakers on all the sites, we don't have statistics now. We don't have information. We don't have a lot of anything to see what's really happening in real time as far as reporting. So again, I think we could gather that for immediate transfers. But again, as far as us necessarily acting on those, or as you said, Mr. Carlton, well, are they kind of self-reporting on themselves? Even under OBA, we were not acting upon those. Now, obviously, if there's, you know, serious patient harm or death, we could look at them, but just the event in and of itself would not be a triggering event per se to do a complaint or anything. Now, if one clinic has all of the emergency transfers reported, well, certainly that might be something. But again, a lot of this is just to assemble the information to know what's going on out there. It is not necessarily to immediately, you know, act on a complaint or to consider these complaints. And I think we just need to be clear on that. And the intent, as I said when I started, was really for everybody's purpose to gather the information. You know, Dr. Zafran, we've heard from a lot of folks that have concern, and then you hear from a lot of folks, but is it really happening out there? And right now we don't know. So that was one of the purposes of gathering the information, whether it's an immediate report or for that one particular segment, and then everything else at renewal. That's what we're looking for, to be sure this rule is crafted appropriately, and if it does need to be modified. The issue is, if you begin splitting it up, are we really going to be doing anything with those events? I mean, short of saying there is serious patient harm or a patient death, which we would act on independently, regardless of where it came from, ketamine clinic or any other setting.
Yeah, I think I was talking about this with Brent and Chris. You know, I do think that there probably needs to be somebody looking at this. I mean, you know, obviously Dr. Shinava as our CMO or as our medical director, it may be appropriate for him to review these automatic reports that come in for transfers. And, you know, number one, either it's something that sounds so egregious that it needs to have an investigation opened, or it allows us to see that there's patterns occurring in certain places that may also trigger something. So that way we're at least getting eyes looking at it. And frankly speaking, if the volume is going to be so high, that in itself tells us something that we need to address. So either way, somebody making sure that they at least review it, it's going to give us an answer one way or another. Either the volume is really high, which is a problem in itself, or we're able to identify certain things that probably needs to have an investigation opened up, but certainly not necessarily an investigation on every single event that is reported.
Well, and I think in fairness, if we don't get any reports, that's also indicative that the rule's probably working. And a lot of the speakers that are saying we're not having issues are borne out, which is both sides have had a concern over what information. basically the information vacuum right now. So this is a good place to fill in the information vacuum that we all suffer from.
Correct. All right, I think Dr. Green and then Ms. Troncoso. So Kelly?
I think it's important to have, and you don't have to parse it out into two separate check boxes, but just one, report of serious adverse events, including transfer to a higher level of care, a different facility, and patient something, some wording, patient death or hospitalization within 24 hours of the procedure. I would like both of those in there.
All right, Linda?
So, and this is my naivety over how the system works, but as we're talking about the vacuum of information that we have, is when somebody comes in, say MindBloom or one of the other facilities that's doing telehealth, sends, oral or nasal spray stuff, and somebody ends up in the hospital, do we have the data to be able to figure out what's happening? Like, do we receive that from hospitals saying, hey, we've had this many ketamine patients this year or this quarter? And is there a way to, and this isn't today's problem, but is there a way to address the rules so that as we talk to the legislature coming up and as we look at those things, we can try to start gathering that data to figure out how we can address it?
So, I mean, obviously, this is kind of just, addressing stuff that are done in clinics and not at home. But I think as the legislature starts looking at that, I do think addressing reporting requirements, I think is important, Linda. I mean, there's a lot that's happening out there that we hear about, but unfortunately, the only time we hear about it is when there's a lawsuit and it becomes public information. And, where you see one lawsuit, there's probably 10 or 15 or 20 cases other than that lawsuit that are out there that didn't reach the level of a lawsuit. So we know it's out there. But to your point, how it gets reported, how we get that information. So obviously some of it is beyond the scope of our board, but it certainly needs to be part of the conversation, when and if this gets to the legislature, especially when we're talking about home-based or home use ketamine also, or other types of drugs that may be, that may have psychedelic effects.
Thank you.
All right. Any other comments? So right now I've heard of a couple of editorial suggestions. One is changing the ordering, and actually it's an appropriate change because it's an alphabetical order. The other was adding the delegatory language after another 3 areas where we didn't have that specific language there. And the third one was adding affirmative reporting in areas where there is a transfer from the clinic to a hospital or facility by EMS. Am I missing anything?
There was
Brent,
one more
Scott?
thing that you recommended, and it was on the putting it such as, but not included, or not.
Oh yeah, such as, but not but not limited to.
Not limited to.
Yep. All right. So those are all the changes that are being suggested. Is there any objection to any of those suggested changes or questions by the board members?
Well, as far as the language for mandatory reporting, Scott, I know we're kind of doing this on the fly here. So what if we immediately after 173.15, okay, what if we put in a new 173.16? We'll have to renumber the ones after that, which again is not a big deal. There's only a couple after it anyways. But what if we have a new 173.16 and it's just titled mandatory reporting? And it says the medical director must ensure the PKT practice completes and submits the board approved form within 24 hours anytime the following adverse events occur: A, emergency transportation, or B, death.
Okay.
That's perfect, because you would presume that death would not end up with transportation to a facility, potentially. I like that proposed change. Or
Do we
addition,
need to
I should
include
say.
hospitalization as well, or is that also included with emergency
No, I think if you're
transportation?
going to have transfer to a facility, then that includes because they may get discharged from the ER, which may not be hospital. So I think just saying transfer by EMS would cover that.
Sounds good.
And trying to keep it tied to what's already in the adverse event definition to not have, something that's outside of those kind of 6 things that are there.
Because this has already been reviewed appropriately. So we don't want to open up to things that go beyond what we have in there that may, trigger some further things that we have to do ahead of time. Any other discussion or comment? I think all of you is there any questions about what we're suggesting as far as changes and additions right now?
Scott, you feel like your team has all this?
Well, I have my team here. Sarah, Wendy, Kamisha, you've heard the suggestions, and I think the only one that takes a lot of, and really not a lot of effort, is the affirmative reporting on that. And I think if we make a 173.16 that says something.
I sent you the
proposed language. I saw that.
Yeah.
So Sarah, can you get those incorporated? Now, we haven't taken the vote, but we're going to presume that those amendments are going to be sought in the motion. So if you'll incorporate those now, Sarah, Wendy and I will handle the voting and presume that the suggestions under delegating authority, such as but not limited to the transfer, and then of course to be sure our order's correct on our definitions. If you would start working on those right now, I think we will be able to do those unless something happens in the voting, and if it does, well, we will react accordingly.
I have one suggestion to make. You've got a section on adverse, as you know, a proposed section 173.14 on the specific deadline for reporting and the affirmative duty to report, rather than creating a new subsection 173.16. I would recommend that you keep it all in one area under 173.14 and add it as a new subsection there. I suppose new subsection F.
Would it be F,
that's
Sarah?
the way people, I'm sorry?
Yeah, you put it in as an F, so it's a continuous section that's the full responsibilities under adverse reporting. Is that where you're going, Sarah?
Yeah, that way
agree with
people
Sarah.
just
I
look
think
in
think
one
it's cleaner.
spot, and
Mhm.
they don't, they're not required to kind of comb the rule for every single area where something in connection with that reporting might be required.
I think Brent and Dr. Zafran and the board members, y'all, as long as it's there, you're okay with the staff suggestion.
No, but I think it makes sense. Yeah, I think it makes sense having it there. Yeah.
Proceed like that, Sarah. That will be fine. That's a good suggestion. Appreciate it.
Okay, board members. So again, you have the suggested changes. Is there any other questions or suggestions? All right, so unless there's other further discussion, is there a motion on the rule with the addition and change and suggested changes that have all been made that we discussed? And I can repeat them again if need be.
I'll make a motion, Morgan, with the changes.
Second to Stephanie.
Wait, what was the motion first? Is the motion to accept the rule with the proposed changes as discussed?
Yeah, with the proposed
Okay.
changes, yeah.
All right, so it's to accept the
Second,
rule
Vanderline.
for publication.
Second
All
to
right.
Stephanie.
And we have a segmented. Now, is there any further discussion on the proposed motion? Seeing none, all those in favor, please say aye.
Aye.
All those opposed? All right, the motion passes. So just for everybody to understand, this will be sent out once the changes have been made to be published in the register. And when it's published in the register, and again, correct me if I'm wrong, guys, that's when the 30 days are triggered. So, because I know there's questions about that. It took a couple of weeks at one point for it to get published in the register, and there's confusion as to when does the 30 days, when are the 30 days triggered? The 30 days triggered when it appears on the register.
Yeah, it
We're
should
gonna
appear on July 10th.
Okay. So if it appears on July 10th, then it will be 30 days from then, which would still get us to be before our next board meeting, which would allow us to be able to consider the rule with comments that have been brought in by our next board meeting. And then at that next board meeting, our ability to either pass the rule as is, make non-substantive changes, make some more substantive changes, and just, continue on with reconsidering it with another going out to the public for comment, or not adopting it at all. Those will be our options at that point. So with that, I think unless there's any other questions, we'll move to the next agenda item.
All right. Yeah.
All right.
So we're at 4B. The rest of these should go pretty quickly. 4B is chapter 161, specifically. It's going to be 161.35. This is continuing medical education requirements for license renewal. These are coming from this past legislative session. So you have there in your rule, this is talking about for forensic evidence collection and also for nutrition. Both of these are CMEs, again, that are required out of the last session. So we just need your approval to publish these also for the 30-day comment period.
I'll make a motion to publish them for 30 days, Kokonos.
Okay, so we're made a recommendation by Mr. Kokonos.
Deloche, seconds, please.
Seconded by Dr. Deloche. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? All right, motion passes.
All right, 4C. Here we go. This is going to be in chapter 168, specifically rule 160.8, employee training and education. This also is a new rule, but it's in line with the current State Employees Training Act in Texas Government Code 656041 to 049. This will allow the board to reimburse staff that engage and participate in education or training programs that will allow them to have skills and requirements that meet their job description.
All right, so before you is a proposed rule. Is there any questions on this proposed rule? And if not, is there a motion on this proposed rule?
Move to approve, Troncoso.
All right, so we have a motion to also publish this rule to go out for the public comment period. Ms. Troncoso, is there a second?
Seconded by
Del Rosal.
Rosal. And is there any further discussion on the motion? Seeing none, all those in favor, please say aye.
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 All those opposed? All right, motion passes.
All right, 4D, we're actually going to skip. We're not going to be doing that one today. So we're going to move on to 4E, Chapter 183, specifically Rule 183.16. This is the same thing, but it's for the physician assistants, as you did for the physicians just a moment ago on the forensic evidence collection. So we would need a motion to approve this rule for publication for the 30-day public comment period.
All right, so before you is a proposed rule, is there any discussion? And if not, is there a motion?
Motion to approve for 30-day comment period, Jones.
Motion by Dr. Jones. Is there a second?
Second, Morgan.
Second, Barnes.
Second by Ms. Morgan and Ms. Barnes. You have a motion and a second. Is there any further discussion? All those in favor, please say aye.
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 All those opposed? All right, motion passes. We've already,
I
go
just
ahead.
want to say, whenever I'm doing the rules, they go really quick. So, I mean, it's,
Yeah. All right.
Well,
so,
in that case, we have to split up the team who has the longer
right, we'll have
agenda
subcommittees
items.
for rules in the future. Yeah.
It's that kernel leadership is what it is, the kernel leadership.
Yeah, exactly. All right, so we've already done the open forum for public comment. I'll just remind everybody that you will probably be getting some direction about the whole committee and subcommittee structure prior to the next board meeting. So we'll try to make that as easy to understand as possible. It'll be a very interesting experience for all of us to kind of all see what the others are doing, but at the same time, hopefully make the process actually more complete, because that way a lot more people will be going through the process, the appellants and so forth, making sure that we have a lot more eyes on it. And hopefully all of us will finish in before sunset. So with that, is there a motion to adjourn?
We also have a consent agenda from April.
Yes,
Wait,
that's correct. Yeah, you're right. Thank you for
sorry.
reminding us. Before adjourning, we have the consent agenda. This is from the meeting you had in April. To put this last rule out for public comment, this agenda is ready for your consideration and approval. So we would need a motion to accept as presented.
All right, motion for the consent agenda. Is there a motion?
Motion to approve the consent agenda.
And I
Motion by
second
Ms.
it.
Morgan.
Dr. Mark seconds.
Second by everybody else. Any further discussion? All those in favor, please say aye.
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 All those opposed? All right, now, is there a motion to adjourn?
I motion to adjourn.
All
I
right, motion
second.
adjourned by Mrs. Rosal. Is there a second?
Second.
All right, second, I think I saw Ms. Barnes at least. Any discussion? All those in favor, please say aye.
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 All those opposed? We are now adjourned at 11:22 a.m. on June 29th, 2026. I'd really like to thank all our board members for our impromptu board meeting. This was a very important discussion, and I'll see you again, everybody, in August. Have a good summer.
Have a great
Thank
day.
you.
Thank you.